Good morning. I'm Dr. Susan Bursoff-Macha, Deputy Director of FDA's Office of Women's Health, and on behalf of the Office of Women's Health and the Office of Clinical Pharmacology, welcome to today's workshop, Menopause, Potential Impact on Clinical Pharmacology and Opportunities for Future Research. We have a very exciting workshop planned with experts from across the field. Before we dive in, I would like to share a few housekeeping items. The Office of Women's Health and the Office of Clinical Pharmacology coordinated the scientific conference to bring together experts who will share their research and insights with scientists, clinicians, sponsors, and the public. The speakers' comments do not necessarily reflect the views of and are not endorsed by FDA. All presenters are expected to use generic names for products whenever possible and have been instructed not to promote off-label use of any products. Following each panel presentation, there will be time for audience questions. During the meeting, questions and comments may be submitted through the Q&A function, and at the close of each panel, our speakers will answer as many questions as possible. Speaker bios and other meeting information is available on the FDA Office of Women's Health webpage, and the meeting recording will be available from this webpage within 2 weeks after the meeting concludes. Before we begin today's scientific talks, we will hear introductory remarks and a keynote presentation by FDA's Associate Commissioner for Women's Health and Director of the Office of Women's Health, Dr. Kavitha Vasisht, and from FDA's Principal Deputy Commissioner, Dr. Janet Woodcock. Now, I will hand things over to Dr. Kavitha Vasisht.
Thank you, Susan. Good morning, everyone. On behalf of the U.S. Food and Drug Administration's Office of Women's Health, I'm pleased to welcome you to today's public workshop, focusing on menopause and its potential impacts on clinical pharmacology. The Office of Women's Health works to protect, promote, and advance the health of women through policy, research, outreach, and educational programming, such as today's workshop. Our topic for today's discussion is menopause, a normal part of aging for women. And although our collective understanding of menopause has and continues to evolve, what is less well understood is whether and how menopause affects drug pharmacokinetics and pharmacodynamics. We feel this is an important discussion. Many women will enter the menopause transition needing to continue medications for various health conditions. Today, experts in the fields of clinical pharmacology, obstetrics and gynecology, and endocrinology will discuss the biologic and physiologic changes that occurred during the menopause transition, including considerations around perimenopause, surgical versus natural menopause, and the impact of age, race, ethnicity on menopause. Our experts will then explore the potential effects of menopause on pharmacokinetics and pharmacodynamics of drugs and how this could be considered during medical product development. Today's discussion will highlight data and knowledge gaps and identify areas in need of further research and exploration. Ultimately, a deeper understanding of menopause will enable us to provide more personalized care. I would like to express my gratitude to our FDA colleagues and our distinguished speakers and moderators for bringing all this expertise to the discussion today. A special thank you to my incredibly talented and dedicated staff in the Office of Women's Health and to our FDA's Office of Clinical Pharmacology for their collaboration and partnership in developing this workshop. Dr. Erin South and Dr. Susan Bursoff-Macha led the development of today's outstanding program, and we would not have been able to make this virtual meeting a reality without Dr. Lorene Demekpour, Alexandra Reed, and FDA's IT team. Today's program underscores our dedication to advancing our understanding of women's health topics and promoting research in understudied areas. We hope that this meeting will result in a collective commitment to better understand menopause, as well as encourage researchers to incorporate women's health research questions into their work. So thank you for joining us today. It is now my distinct pleasure to introduce our keynote speaker, a woman whose illustrious career has left a significant impact on public health, FDA's Principal Deputy Commissioner, Dr. Janet Woodcock. Dr. Woodcock?
Thanks very much, and good morning. I thank the Office of Women's Health and the Clinical Pharmacology Office for organizing this workshop and inviting me to participate in a very important discussion on menopause and its potential implications and impact on the clinical pharmacology of drugs. So our Office of Women's Health really leads many efforts to help bridge gaps in knowledge of the health of women. And I'm really glad to see this collaboration with the Office of Clinical Pharmacology. October is World Menopause Month, and today's workshop is critically important, not only for the 62 million women in the US who are currently menopausal or postmenopausal, but more than the 1 million women in the US who will experience menopause this year. This is often a time of tremendous transition and change for women. The average age of menopause in the US is 51 years, but of course, many women begin experiencing symptoms years earlier. And as Dr. Vashish said, there is also medically induced menopause that people have to go through. And with increased longevity, many women are experiencing more than a third of their lives post-menopause. And the rapidly changing demographic of the postmenopausal population is really astounding and highlights important opportunities and needs for research and further investigation. Now, I'm pretty old myself, and when I was growing up, people didn't discuss menopause in public. In fact, it was only behind closed doors and mainly something that women discussed or physicians. So I'm really glad to see that this natural feature of biology has kind of come out in the daylight, and we're discussing this as a normal state of humans at a certain point in their lifespan. But regardless of this, and possibly as part of an consequence of the fact that it was somewhat unmentionable many years ago, very little, we've learned a lot about menopause itself and its natural history over the last 30, 40 years, but very little is known about the effects of menopause and perimenopause on the pharmacokinetics and pharmacodynamics of medical products. And advancing the health of women, of course, requires a look at all aspects of female physiology at all stages of life. Now, in recent decades, FDA has made great strides in including women participants of all ages in clinical trials in many disease areas and conditions. And we've had big leaps in the knowledge of sex differences in product safety, efficacy, and dosing. And this is really important since women are more likely to use prescription medications than men. This has been long known. And polypharmacy, or use of a lot of medicines together, is more prevalent in women than in men. FDA has a long history of developing policy, regulation, and guidelines on the enrollment of older adults in clinical trials. And this has been a real success. Optimizing medication use in older patients really does present unique problems. Older adults often take multiple prescription meds and many other types of over-the-counter medicines and dietary supplements and so forth, and they might be underrepresented in pre-market drug evaluations, leading to insufficient data on how they work in these populations. So specific data on the safety and effectiveness of new medications likely to be prescribed in older adults, especially those at the very end of the age span, are critically needed. And of course, older adults are at greater risk of adverse drug effects, drug-drug interactions, and even adherence challenges. Now, in women, the hormonal changes of menopause are significant and complex. And there's limited literature that specifically evaluates how the circulating level of sex steroids impact drug efficacy or adverse reactions. And of course, we have people taking replacement therapy too, which adds to the complexity. Gaining a better understanding of the impacts of menopause will advance women's health enable us to better meet the needs of women and reduce morbidity in women during this life transition. Now, in today's workshop, as we already hear, we'll hear a dialogue among leading experts in clin pharm, obstetrics, and gynecology, endocrinology, and gerontology. And I'm really happy that OWH, in collaboration with the Center for Drug Evaluation and Research, is offering this opportunity to explore and tease out complicated factors related to menopause, aging, sex hormones, and clinical pharmacology of our regulated products, particularly as medicine moves toward individualizing treatments, which is what basically at the end of the day is going to be needed. So I really hope and believe you'll find today's workshop informative. I look forward to discussion, and I believe it will move the field forward. Thank you very much.
Thank you so much, Dr. Woodcock. And now we'd like to welcome the moderator for our first session, Dr. Christina Chang. Dr. Chang is the Director of the Division of Urology, Obstetrics, and Gynecology in the Center for Drug Evaluation and Research at FDA. Welcome, Dr. Chang.
Thank you, Dr. Bursav-Macha. Welcome, everyone. I'm excited to be a part of our first panel of the day, overview of biologic changes of menopause. As a reminder, meeting attendees may type their questions for our speakers in the Q&A function, and we will address questions as time permits at the end of this panel. The views and opinions expressed in the presentation represent those of the presenters and do not necessarily represent an official FDA position. I am pleased to introduce our first speaker, Dr. Nanette Santoro, who is a professor and the E. Stewart Taylor Chair of the Department of Obstetrics and Gynecology at the University of Colorado School of Medicine. Her current research involves treatment of menopausal symptoms in women, understanding the mechanisms by which obesity causes relative infertility in women, clinical trials in reproductive medicine, and research training of OBGYNs and reproductive endocrinologists. She was elected to the National Academy of Medicine. Welcome, Dr. Santoro.
Thank you very much. I'm going to share my screen, hopefully without much ado. Everybody can see that? Great. Okay, so what I would like to walk you through in the next 20 minutes, these are my disclosures with one misspelling, is to talk about the stages of reproductive aging, because there are some pretty profound reproductive hormonal changes that occur over about a 10-year period, and this may be very relevant to how drugs are handled by women, and little is known, as has been said. So linking those with some of the biological and psychological changes that occur and cause symptoms, which also may involve the use of additional medications, and differentiating natural menopause from surgical and iatrogenic menopause. So the optimal bleeding criteria to identify the stages of the menopause transition have been worked out in a very large number of epidemiologic studies and harmonized in worldwide studies. This only, of course, applies to women who have some regularity of their menstrual cycles in their mid-reproductive years, and also to women who are not taking things like hormonal contraception. But what you can see here on this very busy slide, what I want to call your attention to is the menopausal transition here, stages -2 and -1, with the final menstrual period being 0. And this early to late transition is a point where there's probably the most change. And that's where you'll see again and again, spoiler alert in my slides, where we see more of the biological changes happening. So this duration of amenorrhea of about 60 days identifies that late transition. The early transition is a little more squishy because you need more than a 7-day difference in the length of consecutive cycles, which some women will not be paying attention to, but in the age of Apple Watches and apps that do that, many women may be able to pick that up. But most often what a woman will pick up as she enters the transition is she may go from some subtle changes in her cycles to some more variation or a skipped cycle. But once you hit that 60 days, you're in the late transition, and that tends to be about 1 to 3 years almost all women are through this by 4 years. So what are the sequence of events? We know ovarian reserve and the oocyte supply in women is fixed. And as this is clinically silent and cycling continues, a critical level is reached. And less anti-Müllerian hormone, less of the inhibins, which are made by the group of growing follicles in the ovary, lead to less restraint on FSH. So FSH goes up, but we're not at a point yet where the follicle supply is exhausted. So there's still some follicles. So cycles tend to become shorter. There's more rapid cycles. The follicular phases get shorter, so the time to ovulation. And follicle maturation looks like in some cycles, it can even begin before the next menstrual period. So this results in patterns that are relatively chaotic and a little more exaggerated when compared to mid-reproductive patterns. We always think that estrogen is just going down in this sort of progressive way in the transition, and that is not the case. So this is a simplified version of straw that I've made that just shows, again, pre-transition, normal reserve, regular cycles, relatively few symptoms. The early transition, women have skipped cycles usually, or that 7-day difference. The median age is about 47. The late transition is the speed bump that you can see here. And that's when women have that prolonged amenorrhea, median age at 49, but there's quite a bit of variation. So the net result of those changes in the early transition as cycles get shorter are menses are more frequent. There are longer luteal phases relative to the follicular phase, so that women that have struggled with PMDD in their 20s and 30s are likely to have prolonged PMDD. They're either having their period or they're post-ovulatory. And there's wider hormone excursions. So this often translates into worsening of migraines and some greater of what we call menstrual magnification of pre-existing conditions that were more tolerable in reproductive life. Migraines, some things like asthma, chronic fatigue type symptoms, many patients will report are worse. Let's face it, few things get better during menses. So more menses just means that people generally feel a little bit worse. And this just illustrates the sort of exaggerated patterns that you may see that show what's happening here on the bottom is with the ovaries. You can see that there are waves of follicle growth that happen independent of the cycle. So here's one menstrual period shown in the bar, and the next menstrual period is over here. 3 waves of follicle growth have happened. One of those, the first one, leads to a normal follicle growth and a normal estrogen level, and what we consider a normal, but that's really a mid-reproductive because menopause, I mean, the process is normal. But now you've got this sort of renegade follicle that's coming up in this second wave before menses even happens, and it's piling on with the estrogen that was from the prior cycle, making an even higher estrogen peak, which Georgina Hale has called the out of phase or loop cycles. And you get this doubling or even tripling of the estrogen level. And this can be seen in a variety of cycles. In the SWAN study, we looked at thousands of cycles and saw this in maybe 15% of them. And Dr. Hales identified it. So these can be uncomfortable for women. These are shooting hormone levels up into the area of pregnancy levels and can give some additional symptoms. This is some data from my lab when I was first starting out. And again, this is a single perimenopausal woman. These are her gonadotropins. She collected urine for us for a whole year, but I'm only showing you 6 months here. And gonadotropins go up and down, but mostly they're reacting to what the ovary is doing. So the action is on the bottom here. And you can see in these dark squares, there's progesterone metabolites being produced in the urine. And there are 3 bumps of progesterone metabolites. So in 6 months, this woman ovulated 3 times. This on the left is a more mid-reproductive type of pattern with estrogen, and E1 is estrogen conjugate, so that's estrogen metabolites in the urine. And this is what we would call pretty normal looking mid-reproductive cycle. This one is a little bit robust. And then she stops cycling completely. Her ovary is unable to make any follicles for about 30 days. LH and FSH go up, and then she has this massive production of estrogen. And this is about 7 times what we see in a mid-reproductive cycle. Again, towards the levels that would approach pregnancy. They come crashing down. She reported a very heavy menstrual period. We advised her to see her doctor. She never did and had a very uneventful menopause. And then right away goes into an ovulatory cycle, and then things kind of wind down again. So these patterns are erratic, they're a little extreme, and they may influence symptoms. By the time you get to the late menopause transition, the ovary is now at a point where it has fallen and it can't get up. It's having trouble making follicles on a more regular basis. And that's the 60 to 364 days of amenorrhea. By the time a woman gets to 365 days, she is declared menopausal by dates. Some women will still have a bleed after that, about 5 to 10%, but we tend to think of that as being menopause. That's kind of it. This involves more prolonged stretches of low estradiol, and this is where more classic symptoms that we associate with menopause start to happen. And this is the hot spot for when hot flashes, vaginal dryness, mood and sleep changes that have been associated with the menopause transition really begin to pick up. And this just shows you some of the changes in hormones if you just look at a single blood test in the years around menopause. And this is where FSH and estradiol levels cross. So FSH is lower when estrogen is higher prior to that final menstrual period. Then they cross, FSH goes up and stays up, and estradiol for the most part stays low to very low. And interestingly, as pointed out before, you can see some of these changes in inhibin, and inhibin's a hormone made by the ovarian follicle as it is growing, and the growing follicle pool declines, is getting lower earlier than that. So that's when we see those signs of low ovarian reserve that start to make those critical changes in the menstrual cycle. We also see changes in luteal activity, so progesterone production. Almost all of the cycles that we looked at in the SWAN study, and again, this is thousands of menstrual cycles, about 9 to 10 years prior to the transition. These were regularly cycling women in their mid-reproductive years. They continued pretty much regularly cycling with ovulatory cycles, with only a small decrease in their ability to have ovulatory appearing cycles until the very end of reproductive life. So those last couple of years is when anovulation becomes more of an issue. So what happens? How do these hormones translate to symptoms? And this is the 7 dwarves of menopause. So we have sweaty, sleepless, bone dry, grumpy, anxious, dopey, and sexless. I will dwell on most of these, not so much the sex. It's a little more of a murky area in terms of hormones causing it. But the core 4 that have really been shown, and in an NIH conference in 2005 with some modifications in 2008, to be associated with strong evidence that they are associated with menopause, and they tend to get better with hormone therapy. Vasomotor symptoms, almost 80% of women will report them. Far fewer report very severe ones, but they are disruptive. Vaginal dryness, depending on how you ask the question, varies tremendously, from 25 to 80% of women. Depressive symptoms and major depression, 15% risk for major depression is quite significant, and about a quarter of women will report sleep disruption. There's mixed or weaker evidence for urinary incontinence being directly related to the transition, as well as low libido and reduced metabolic rate, but those are all additional concerns that are under study. So hot flashes tend to be the biggest driver. That's the single symptom that tends to drive women to seek clinical attention. In the premenopause, women are affected. There's a proportion that will report hot flashes, but they are usually mild. In the pre to early perimenopause transition, what I showed you before, as women begin to skip cycles, that proportion tends to go up. And the early to late, as they trip into that 60+ days of amenorrhea, up to 80% of women will report it. They stay high in the peri to postmenopause. They start to go back down again about 5 years after, but we have learned that they can last a lot longer than we used to think. And here is some data from SWAN. Women were asked if they experienced hot flashes over the last 2 weeks. And these are the women who said yes. The left side shows when they appeared based on the first report, and the right side shows race and ethnicity. And you can see that if you've had them premenopausally, which is this black line, 12 years later, about 3/4 of women are still reporting hot flashes. So we used to think it was self-limited, not a big deal. That is not a great history there. These are people who may well need long-term treatment. If they appear in the early perimenopause, they tend to go down, but you don't reach the 50% point until 10 years. And women who get them postmenopausally or in the late perimenopause have the shorter duration. So if they appear late, it actually gives us some ability to help patients predict what's going to happen. By race and ethnicity, SWAN used self-identified race ethnicity. Therefore, this is a social construct. And we looked at very substantial numbers of African-American women, Chinese women from Northern California, Hispanic women in the New Jersey area. Unfortunately, we did not have Mexican-American women in this cohort, and Japanese-American women. And you can see differences right away, just looking at the graph, with African-American women being the superstar hot flashers, with 11 years until they reach that 50% point, and Hispanic women falling a little bit in between the white and the African-American women, and Chinese and Japanese women having the least, and again, the shorter experience. So again, another way that we may be able to help patients forecast what may be in store for them. So in this population-based survey, which was the best one that I could find, even though it's from 2007, it looked at 3,000 women aged 40 to 65 and found that 60% sought care for symptoms. This is actually very similar to what was found by Janet Guthrie in the Melbourne Healthy Women study in Australia. So that 2/3 number is maybe pretty reliable. So women will come in, usually because of their hot flashes. And when you look at what they use, about 1/3 used hormone therapy, 12% used complementary and alternative medicine, and 16% used both. It's a little sad on the complementary and alternative medicine because we actually have pretty good evidence that they are not effective. But that leaves about 40% of women untreated. And this is a gap that needs to be understood better. Were they untreated because they just felt like their symptoms weren't that bad? They were happy to understand what was the cause, or were they untreated because they were afraid of all the possible treatments? We just don't know. We think vasomotor symptoms may not be completely benign based on work by Rebecca Thurston. The level and the timing of vasomotor symptoms seems to be associated with cardiovascular disease risk and also with events. So when you look at a risk predictor, carotid intimal medial thickness, IMT over here, you can see based on the trajectory of vasomotor symptoms, if you have not very many, or you have late onset with that 4 to 5 year duration, you do not have much accrual of carotid intimal medial thickness. But if they start early, and if you have high reporting, very frequent ones, you have more. When you look at the cardiovascular event rate, so now we're looking at a harder endpoint, who actually gets a heart attack or heart disease. If you've got vasomotor symptoms more than 6 days out of the last 2 weeks, you've got a higher trajectory of heart disease, and there's intermediate trajectory for women that have 1 to 5 days out of 2 weeks. But the frequent vasomotor symptoms gave a hazard ratio of 1.5, which seems to be meaningful. What we do not know is if you treat them, can you improve cardiovascular risk? It may simply be that this is a marker for people who are at higher risk, but in any case, it does help inform clinical care. So I want to spend the last couple of minutes on what happens when menopause is sudden or too early, surgical menopause prior to age 45, or primary ovarian insufficiency, premature ovarian failure, less than age 40. About 1% of the population experiences this at less than age 40. about 5% prior to age 45. Symptoms overall seem to be similar for the core four, but they do seem to be more severe and maybe prolonged compared to women undergoing natural menopause. There have not been a lot of good studies in this area. And we do know that disease susceptibility is increased. And it's an interesting conundrum when we talk about pharmacology in these settings, because these are younger women. And in menopause, we have women who are older and having these hormone changes. There may well be differences in the medications that we apply, although we apply them in the same way. So premenopausal oophorectomy means women will have many years of life without hormones. They have worse menopausal symptoms. They are likely to have longer term consequences because more years of life will be spent being exposed to bone resorption in excessive formation. And the possible long-term consequences include increased risk of mortality, some increased risks of cancer, not breast cancer, that's the one you have the least increased risk for, mood changes, dementia, and a small increased risk of cardiovascular disease. So the symptoms are believed to be more severe, to expand to sleep, mood, hot flashes, and vaginal symptoms. And if you do have a premenopausal oophorectomy, it's an independent risk factor for failure to ever wean off of hormones. In the Olmsted County study, which is Walter Roca's work, which is one of the best models that I know of to look at this, he compared women that had one ovary removed to 1,000 that had bilateral oophorectomy and 2,300 referent women who had natural menopause. And all the surgeries were performed over a 37-year interval of time. And when you look at a forest plot of multimorbidity, you can see that the hazard ratios for most diseases are falling to the right here. There are few things that are look like it's a benefit. So significant improvements look like it's for one of these conditions, congestive heart failure. Just about everything else is neutral or falling on the line of significant problems. And they are kind of in the odd categories of things you might not expect. So for example, here you see arthritis in all the oophorectomy groups. Cancer of all types can go up. Asthma is increased in some, pulmonary disease, and of course osteoporosis. And other things you would not necessarily link to hormones. Some conditions like depression and anxiety, sorry about that. Substance abuse, dementia risks, and cardiovascular risks. So this makes us think hard and long about who should be getting and when premenopausal oophorectomy should be done. Because when you look at the National Center for Health Statistics, there's over 600,000 hysterectomies in the US, and 3/4 of those entail removing the ovaries. Half are performed on women under 44, and only 10% for cancer indications. But we are probably going to be increasing our risk-reducing oophorectomies over time as we get better with genetic analysis. So if you just do the math on these numbers, that's about 200,000 women per year who are surgically castrated at age 44 or younger. The other issue that happens is women with primary ovarian insufficiency. There are many genetic syndromes that can happen, and those also complicate the management. So these are not just as simple as taking a woman who's had natural menopause and moving it back. There's a number of mutations that we know of, the Fragile X premutation, which has significant implications for that woman's fertility, X chromosome deletions. There's the BPES FOXL gene mutation, inhibin, and the variety of other syndromes that are often specifically involve genes that are working on the germ cell population or how germ cells function. In one study that we did, we surveyed women from a website that was a patient support group for premature ovarian failure. And what we found, we left a lot of write-in areas on the survey, and boy, did we get a lot of information back. Some women reported symptoms persisting for decades, and the usual symptoms of hot flashes, sleep, mood, and vaginal dryness were all present, but more than 3/4 of the women reported brain fog and mood swings, hair loss, dry eyes, clicking of their joints. And there was only modest improvement in menopausal quality of life in sexual and physical domains up to 4 decades after diagnosis. So this led us to think that there's more here than meets the eye. This is not simply like an oophorectomy or early menopause in the same form that it happens with natural menopause. When it happens to a younger woman, it seems to be significantly more severe. So in summary, menopause seems to be both an accelerant and a permanent resetting. It seems to accelerate and precipitate issues with depression and anxiety. I didn't give you the long bullet on this one for the interest of time, but there are some changes in cognition. They do seem to be pretty small and tend to resolve after the transition, but vasomotor symptoms and sleep complaints all appear and can get worse before they get better. Menopause seems to permanently reset processes of urinary incontinence, and because as women age, they will develop worse symptoms. Vaginal dryness does not get better, it doesn't remit, and sleep changes seem to be, again, more permanent. So that's a resetting of a woman's sleep pattern. And with that, I do want to acknowledge the study staff and the SWAN study, because a lot of our information has come from there. And I do want to thank the organizers for calling attention to this issue, which is very important. And I think we're going to leave the discussion questions out. Is that correct?
Yes, thank you.
So I'll stop sharing at this point. Thank you.
Thank you, Dr. Santoro, for laying the great foundation for today's talk, for today's meeting. And our organizers want us to let the audience know that we will be sharing the link to the recording for this meeting. So please look out for an email to all registrants within 2 weeks. Next, I'd like to introduce Dr. Gloria Richard-Davis. Dr. Richard-Davis is a reproductive endocrinology obstetrician gynecologist and the executive director of Division for Diversity, Equity, and Inclusion in the Department of Obstetrics and Gynecology at University of Arkansas for Medical Sciences. Welcome, Dr. Richard-Davis.
Oops, there we go. Thank you so much, Dr. Chang, for that introduction, and thank you to the organizers of this conference for the opportunity to present on this topic. I'll start to share my screen. I don't. There we go. Okay, so my topic is to discuss the differences in menopause experienced by women of color. What we know is the women of color is a growing demographic in the United States. And what we also know is that there is a paucity of data, specifically looking at how race and ethnicity affects menopause for women of color. We know that we have individual differences, and we all experience menopause slightly different. I think Alicia Keys captures the essence of how most women feel when they have vasomotor symptoms. I know that I can certainly resonate with this, where you have your own internal furnace going. These are my disclosures. And these are the learning objectives. It's just to discuss differences related to race, ethnicity, and genetics as it regards physiology, as well as onset symptoms and development of additional diseases. We'll talk about the impact of race and ethnicity on the onset of menopause, and also to discuss the gaps in knowledge and areas where research is most needed. In the US, women in the plus 50 range accounts for almost 20% of the population. And the number of minority women have also markedly expanded, such that about 1 in 5 people in the US is a woman of color. The minority population also varies depending on region, the South and the West having the greatest density of minority population, and some of our states have the majority minority populations like Texas, California, DC, Hawaii, and New Mexico. This is another way of looking at our demographic shift, such that we expect the population of minority women to increase to almost the equivalent of white women by 2050. Can't have a conversation about race and ethnicity without discussing the social determinants of health and the impact on health outcomes. What we know is that only about 20% of our direct clinical care accounts for our health outcomes. The other 80% is really impacted by those social determinants of health, which is, education level that is attained, lower, which translates typically to lower household income, neighborhood or built environment, which is less healthy, with transportation, as well as access to healthy food being an issue. What is our healthcare? What's the healthcare and health access issue in communities that are under-resourced? And of course, the social isolation and the social network within those communities affects the outcome, the health outcomes. And Black races tend to be more adversely affected. What we know, I want to just note, is that though women of color, Hispanic and Black women, are achieving college education at higher rates now, it's not directly translating to upward mobility as we see in white women. There are 3 studies that is referenced here that specifically looks at the timing of natural menopause based on race. And the first 2 studies, the Healthy Women Study, which is about 540 some odd women, and the SWAN study, which Dr. Santoro went through, both indicate that African-American women experience menopause at an earlier age. For Healthy Women, it was 48.5. For SWAN, it was 1.2 years earlier. However, the pan-ovarian aging study really flies in face of that. And their findings suggest that African-American women experience menopause slightly later. So there clearly is some conflicting data with regards to that. But the preponderance of evidence suggests that African-American women experience menopause earlier. Dr. Santoro talked about the SWAN data, and it's important to note the diversity of the population that was studied, because a lot of information that we know with regards to race and ethnicity really is arising from the SWAN data. There are racial differences with regards to the hypothalamic pituitary ovarian axis. And again, our body of literature is variable. There are studies that have shown variation in estradiol level in African-American women from lower premenopausal levels to estrogen being inversely associated with BMI in premenopause women. SWAN even looked at genetic potential factors as it relates to hormones, where the aromatase gene polymorphism was associated with higher estradiol to testosterone level and was more prevalent in African-American women. Again, variation in FSH level, obesity playing a role, but being somewhat inconsistent as it relates to estradiol level. And the bottom line is it is very difficult to reconcile some of these differences. And so we do need more research in this area. I'm going to reference these 2 papers in particular in the next couple of slides, and that is Dr. Harlow's summary of disparities in reproductive aging and midlife health between Black and white women from SWAN, and also a recent review that Dr. Williams, myself, and colleagues did, where we reviewed over 100 publications and really consolidated the results in this one paper, talking about the experience of African-American women and menopause. We were fortunate that we were recently awarded the best paper from the Menopause Society at our recent conference, so we really are excited and proud of that. But as Dr. Santoro mentioned, vasomotor symptoms really is a hallmark of menopause, and 80% or more of women experience these symptoms. We know that the median duration of vasomotor symptoms is much longer than we were originally thought, and that we would say 2 to 3 years. However, it's more like 7.4 years. The prevalence varies significantly based on race and ethnicity, where Black, Latino women have longer duration and more intensity in terms of vasomotor symptoms than white and Asian women, despite controlling for BMI. And again, as was mentioned, the majority of women with VMS remain untreated in this country. This is depiction really looking at, we talked about the average length being 7.4, but the racial differences are significant, with Black women experiencing menopause symptoms as long as 10 years, 9 years in Hispanic women, 6.5 for white, and then we drop down to about 5 in Asian women. Black and Hispanic women also have more intense symptoms and more frequency in terms of vasomotor symptoms. The prevalence also varies depending on stage. So premenopausal women also have vasomotor symptoms, about 21% reported. In perimenopause, about 41%, and about 42% in postmenopause. And again, variation significant by race and ethnicity. Some of the risk factors with regards to VMS and worsening of the symptoms is low socioeconomic position, low educational attainment, obesity, tobacco use, all of which we talk about being more prevalent in underserved and communities of color, as well as hysterectomy and oophorectomy. When we look at the incidence of hysterectomy and oophorectomy performed, Black women are more likely to undergo hysterectomy and BSO. In fact, in the Southeast area, over 45,000 BSOs are performed annually. So how does perimenopause and menopause affect African-American women? We enter perimenopause and menopause earlier. We have higher rates of early or premature menopause. There's a longer transition even from perimenopause to menopause. Symptoms are more severe and longer. And despite the fact that we're more symptomatic, we're less likely to get prescriptive treatment for menopausal symptoms, which I'll address later. We also know that VMS negatively impacts many other symptoms of quality of life. In this study, menopause quality of life questionnaire was administered. And what we saw is that sleep, mood, concentration, energy, work, even out down to sexual activity were adversely impacted by VMS. Dr. Santoro mentioned earlier that VMS can in fact be a biomarker for future chronic diseases like cognitive impairment. Women with more frequent VMS have more impairment in terms of verbal memory. They have moderate to severe VMS. There's a higher incidence of coronary heart disease or greater subclinical cardiovascular disease with more frequent VMS. And even bone health. We see a lower bone mineral density, increase in hip fractures in women who have more VMS. And I want to just note here that when we talk about chronic diseases in population of color, there's a higher incidence of cardiovascular disease, definitely. When it relates to sleep, this is again coming from the SWAN study. This study by Dr. Matthews really summarized And what they summarized was that white women have a better quality of sleep, longer sleep, compared to women from other ethnic groups. And what you see is that for Black and Hispanic women, health problems, waist circumference, different physical inactivity, all increase the wake after sleep onset, which is, again, disruption of sleep, and those stressors of life. Financial hardship in both groups affects the quality of sleep adversely. For our Chinese and Japanese women, who also have their own factors that affect quality of sleep, it's more related to sense of well-being, and for our Japanese women, also stressors, which increase over time and duration. This is looking at some of the other symptoms and the prevalence based on race and ethnicity. This is data from Dr. Wellens and myself, review of the literature. And what we see here is that for Hispanic women, they're more likely to complain about being tense or depressed. For Caucasian women, more irritability. Again, Hispanic women, more likely to complain about headaches. And for African American women, the more common complaints are stiffness, hot flashes, and night sweats. So difference in obviously the prevalence of symptoms. This is looking at the difference in risk of osteoporotic hip fractures based on race as well. And we see that white women have a higher prevalence compared to Hispanic, compared to African American women. So we know that socio-demographic and cultural influence affects menopause onset, as well as the experience and the symptomatology in women, which includes all of the things that are listed here that we talked about, but also having fewer children, general health perception, and acculturation levels. I want to spend a minute talking about discrimination in our healthcare system. And this is a study that it's a Kaiser study done, which surveyed Black, Hispanic, and white patients about their experience with the healthcare system. And what they found was that 70% of Black patients felt that the healthcare system treated them unfairly based on their race and background. And for Hispanic, it's about 43%. And even for white patients, they said 41%. But when it came to their personal experience and feeling like they were unfairly treated based on race, then you see a marked difference where for Black and Hispanic women, it's about 20% said that they were discriminated against, and only about 5% in white patients. I want to note that there's specific terminology coined called allostatic load and weathering, which addresses the discrimination that Black population experiences, which actually accelerates aging and certainly correlates to increase in chronic disease and poor health. There's a study that we recently published, which did a survey looking at really the attitude, belief, and behavior around menopause. And this was specifically to look at the women's perception, but we also surveyed healthcare professionals. And it was Healthy Women Online survey, cross-sectional survey of over 1,000 women. We also did a very detailed qualitative research study, and over 100 healthcare professionals and women were surveyed. And the results really talked about whether menopause was considered as a medical problem or a natural process. We discussed with the healthcare professionals differences in factors that affected their diagnosis and treatment of patients, as well as what came out of it in terms of summary was that the patients, of course, indicated that they preferred healthcare providers who did not rush them, who were good listeners and had expertise, which is nothing surprising. Though patients use technology frequently because of lack of access, 50% of them said that they were unsatisfied with the use and ease of accessibility to information with regards to technology. This kind of generalizes the perception of menopause by race and ethnicity. And what we see is that when we talk about menopause as a medical problem, white women are more likely to think of it as medical versus minority women think of it as a natural process, despite the fact that there may be greater severity in terms of menopausal symptoms. Another important factor that came out of this study was the reason participants did not take prescriptive therapy for menopause. And over half of them said that the healthcare professional did not suggest it, or they were unaware that there were treatment options. Others had fear of side effects, they felt like it was a natural part of life, so they wouldn't take any treatment, and various other small indications as to why they would not accept treatment. When we look at healthcare cost and resource utilization, it is important for us to note that with worsening vasomotor symptoms, what we see is an increase in healthcare cost that is allocated. So it's important for us to know that women who have more severe vasomotor symptoms seek medical treatment more often and are absent from work more often. And there's a lot more information that's being published with regards to the impact of menopause on workforce. So that data is really evolving very rapidly. I want to mention life expectancy by race and ethnicity because it is important for us to note that the difference in life expectancy based on race and ethnicity is stark in the United States, with the southeastern region having the lowest life expectancy, and the difference being as much as 3 years based on race. I also want to note when we talk about the data that we have from SWAN, that there was no site in the Southeast US. And so that's, for me, a large population that is missing from our evidence. So key questions when we talk about women of color is, what shapes her life experiences? What causes her stress? What's her source of resilience and support? What are her perceptions of her healthcare provider and healthcare generally? What are her social determinants of health? And how does she view her health? How does she feel about menopause? I hope that I touched upon all of these things and gave you a sense of the influence of all of these different components on women of color. Our gaps in knowledge and future areas, from my perspective, is we need a better understanding of factors that worsen menopausal symptoms by race and ethnicity. We have a positive data. We really need much more detail in that area. We need an increased awareness regarding symptoms, severity, and treatment options, as well as concerned about the perceptions and barriers that prevents women from seeking help or receiving help. Further understanding of factors that are the decision points for women of different race and ethnicity. More research in the physiologic, genetic, and social factors that influences menopause onset, duration, and expression of symptoms. More open discussion because there's a lot of stigma around menopause, though it is improving as we elevate the conversation. Healthcare providers need more training in terms of providing culturally aligned, comprehensive evaluation, and to underscore personalization and tailoring of healthcare, because it does differ based on race and ethnicity. And lastly, we need longitudinal studies of multi-racial diverse cultures in perimenopause and menopause, including the areas that I mentioned where we're missing the Southeast. So I leave you with the fact that I feel like we have scratched the surface of what we need to know about menopause, race, and ethnicity. And I'll end there as we will take questions later. Thank you.
Thank you so much, Dr. Richard Davis, for providing the overview of the different factors that may impact menopause onset and the gaps in knowledge. Now, I'd like to introduce Dr. Cynthia Stunkel, who is a clinical professor of medicine, endocrinology, and metabolism at the University of California at San Diego. Dr. Stunkel established one of the first menopausal programs in the US in 1988. She is a founding member and past president of the North American Menopause Society. She chaired the Endocrine Society's 2015 Clinical Practice Menopause Guidelines and co-authored their 2023 Scientific Statement on Hormones and Aging. She has presented to the National Academies of Medicine, menopause leaders at home and abroad. Welcome, Dr. Stunkel.
Thank you so much. Okay, thank you so much for that introduction. And I'm very pleased, and thank you, Dr. Chang, and the rest of the members of the organizing group for inviting me to participate today. These are my disclosures. I sit on a data and safety monitoring board, and I will not be discussing anything related to this activity in my presentation. And along with my colleagues, we're interested in the effect of sex hormone changes during menopause, but I'm going to do a particular drill down to focus on what the metabolic implications are of menopause versus aging. A lot of our ability to even begin to answer some of these questions stem from these incredible prospective longitudinal studies that have been conducted in women going through the menopausal transition. So enrolling them while they're still cycling and continuing them. We've heard a lot today so far about the study of women's health across the nation. The SWAN study, you can see that this is one of the largest studies, and it's just a little bit boggles the mind that some of these women are being followed for more than 2 decades. So I applaud all the investigators on these various studies that have helped us to ascertain what's going on. So from the standpoint of metabolic changes, I thought I would start with this question about bone, because we know that that's an important thing. And the other reason I'm starting with this particularly is because I really liked the way that these authors laid this out. And most of the details I'm going to be showing you about different metabolic issues are going to be in this similar format. So you can see, first of all, that the center of the universe, the stake in the ground, is at the time of menopause, and that's going to be a 0. To the left are going to be the years prior to menopause, during the perimenopause, and to the right are postmenopausal years. So just as you heard from Dr. Santoro, the endocrine changes are shown with a decline in estradiol and a concurrent increase in follicle stimulating hormone, the pituitary hormone that regulates ovarian function. But what we see when we look related to bone is a bump in an increase in blood levels of markers for bone resorption. This says that the turnover is increasing, and this can be a sign of subsequent bone loss. And this is starting to occur about 2 years before the final menstrual period. And then we see this drop in bone mineral density, which is the kind of thing that we can measure on a DEXA scan, for example. And we see this drop again beginning a year before menopause. Women aren't even sure they're there yet, and we're losing bone density. This continues briskly for a few years, and the authors of this paper called this the transmenopause. And the other thing I hope you appreciate is the intervals for each of these factors I'm going to be discussing is a little bit different. But I think the important take home is that there's a lot of action before we know to look for it. Usually we're measuring bone density years later rather than early on. And from the standpoint specifically of this conference, thinking about drugs that are approved to prevent bone loss or to treat osteoporosis, do we know anything about their action in these early days? Very often we look to estradiol, for example, as a potential treatment for this. What I wanted to turn for really the vast majority of my presentation are issues that occurred during the menopause transition and how they affect cardiovascular disease risk. This has been incredibly important. And I think the bottom line of this paper, and this is kind of a global hot point issue right now, this is out of a Lancet publication, is that things are going on behind the curtain that might be very important for the future health of women. So when we think about cardiometabolic changes, if we think about cardiac risk factors, we think kind of the big three: lipids, blood pressure, and blood glucose. So let's start by just looking at what happens with those during the menopause transition. So from the standpoint of lipids, we know that several lipid parameters will increase dramatically in the year or two before to a year or so after the final menstrual period. So this is a change due to menopause, independent effect of aging alone. And they list total cholesterol, LDL, and lipoprotein B. I'm going to focus primarily on LDL because this is what we evaluate when we make decisions about cardiovascular risk reduction. Okay, so here again at the bottom are the years before and after menopause, and this is looking at the LDL level. You can see that this is kind of a little bit tighter than the bone was, just shown a year before and a year after, but you can see how dramatically there's an increase in the slope of what's going on with LDL cholesterol. So gosh, it makes it seem that it's really important when we evaluate LDL in a woman, particularly when we're thinking about how to advise her, again, for preventive strategies. The other thing that happens that I personally find kind of humbling is a reversal in the direction of the association between HDL, the good cholesterol, and cardiovascular risk. Usually we strive for a higher HDL, and we know that this is a very powerful marker of cardiovascular health. But after the menopause, it's kind of opposite. A higher HDL was associated with an increase of carotid atherosclerosis, a marker of cardiovascular disease risk. And it seems that HDL somehow gets compromised. So don't let you or your patients get a false sense of security when their HDL comes back 80 or 90 or 100 or 110, because it's just not working as well. Okay, let's turn to blood pressure. So it's interesting how this field is moving along, because when this original paper was written several years ago, it stated that blood pressure does not seem to have a component related to menopause. Well, not until it does. And last year this paper came out, and it was a careful drill down again of the SWAN data. And the authors said, does menopause matter when we look at trajectories of blood pressure? And the new answer is yes, at least for some. And so let me show you, I think this is an incredible figure. And when I was reviewing for this talk, I couldn't put together why the authors were different, but these were actually the editorialists for this paper that put together this fantastic figure. So looking at women perk along through our lifespan and looking at blood pressure. And they came up with three different patterns: high, slow decline, medium linear rise. So that means just perking along through life, getting higher, higher, higher. But look at this third one, the menopause contribution, where these women were really had a controlled blood pressure. And then during the transition, here's menopause up here, that there was actually a pretty substantial bump. This applied to about 1/3 of the women in SWAN. So that's a substantial proportion. And it was most significant about a year after the final menstrual period. So there are some other factors that can be involved in blood pressure or vascular tone. And so we know that lower estrogen levels after menopause can alter vascular function, the reactivity, and this is sometimes measured in the brachial artery. We know there's more inflammation, but what these authors pointed out that I thought was really important, that there is an upregulation of other hormonal systems. These are the important ones that the kidney and adrenal, renin, angiotensin, aldosterone system to conserve salt, a vasoconstrictor, the sympathetic nervous system, a vasoconstrictor, and a reduction of the important endogenous vasodilator nitric oxide, which would lead to vasoconstriction. So we can see that there is an increase in stiffness, and that some of these changes likely contribute to the development of atherosclerosis risk. So a lot is going on with our vascular health. This is a figure that comes from a Colorado study some years ago now, but really just demonstrates so clearly looking at the path from premenopause through late menopause. And you can see this really textbook decline in looking at brachial artery diameter. Again, brachial artery is sometimes used to examine vascular reactivity. And this was very significant between the early perimenopause and the later phases. And it was even more significant when looked at overall. So things are going on. How about glucose? Certainly diabetes is an important concern. We know that the rate of diabetes in general in the population is increasing. Well, for diabetes, menopause per se was not independently linked to increases of glucose beyond those that we see with age. But, and you've heard a lot about premature and early menopause, in these populations specifically, whether it's natural or early surgical or premenopause, associated with an increase in type 2 diabetes. So we have to be on the alert with these younger women. Why is this happening? Again, I don't think we're certain. We know that visceral fat is a very living, active tissue that sends chemical signals that can trigger inflammation, contribute to insulin resistance. And the other thing that happens with the decline of estrogen is a decrease in sex hormone binding globulin, which escorts the hormones around in our bodies. And what that does in postmenopausal women particularly is increased bioavailable testosterone. So a whole shift in the estrogen-androgen ratio. We know that higher levels of testosterone are associated with insulin resistance. Well, when we put all these together, the lipids, the blood pressure, the glucose, we start thinking about things like the metabolic syndrome. And just to remind you, the metabolic syndrome requires 3 of the following 5 conditions. And you can see we got a little bit of elevated glucose, a little bit of elevated blood pressure, a bump in triglycerides, a drop in HDL. But the new factor in this is waist circumference that differs between most women and then Asian American women. And just the idea being that when we see these shifts in the distribution of weight, not so much the total weight, but the distribution, that this can contribute to risk. So how important is the metabolic syndrome? How prevalent is it? And there's no question that we see that this increases with menopause. The progression and the increase in severity were greatest during the late premenopause, so a little bit earlier, and the perimenopausal years. So that means when this woman starts having changes in her cycle, starts having vasomotor symptoms, it's time to think and wonder if she could be experiencing this. So here's another graph, years before and after menopause. Here's the last menstrual period. And you can see that if women were just perking along at their usual rate, that it would end up much lower. And here's this inflection point in this graph right at 1 year before menopause, and then a dramatic increase in this slope, such that within 5 or 6 years after menopause, we're looking at almost 30% of women who can have metabolic syndrome. This is really important. And then finally, there was enough data to look at this carefully, and the rate of change was more pronounced in Black women versus white women. So another important factor considering race and ethnicity. Well, you heard from some of the earlier speakers about subclinical atherosclerosis. Again, these are measurements of things like ultrasound measure of the carotid arteries or coronary artery calcium, literally looking at the coronary arteries with a CT scan that can give us clues about what's happening from a cardiovascular standpoint, even in women who haven't had any kind of cardiovascular event up to that time. So vascular imaging studies have shown adverse changes during the menopause transition. So again, a lot is going on behind the curtain that extend beyond the effects that we would just consider. So there are marked increases. I wanted to show you this picture of a carotid artery. This is a normal intimal medial thickness. You can see the intima and the media. This is one edge of the carotid artery. Here's the other. They're very tightly placed together. But when we start to build up plaque in our arteries or atheroma, just fatty tissue, then there's a separation of this, and this is a thickening. And that's what can be seen in some women during this transition. Also, there can be some increase and arterial stiffness during this time as well. So the elephant in the room, and the thing that women all notice and women want to talk about, is what happens with weight gain and fat distribution. And I think some of these results might surprise you a little bit. The first thing is that midlife weight gain per se, that says what's happening with the scale, what's happening with the BMI, are explained largely by changes that are chronologic age versus menopause. So can't just blame weight gain on the transition. And studies that have looked at this come up with maybe 4 to 5 pounds. So not huge numbers of weight gain. And you can see in this graph that that's really kind of, again, looking at the years before and after menopause, really not a whole lot's going on right there. But what is important, and what's metabolically very important, are these changes in and adverse changes in body composition and increases in visceral adipose tissue. So what we're actually getting is a change in fat mass versus lean mass. We're getting changes in distribution of the fat mass. And, we're starting to see some organ effects as well. So when we look at that now, we can see that there is a bump in this fat mass that occurs during that transition, primarily occurring about 2 years before the final menstrual period. It's shown that it actually doubles, and lean mass will decline, and this continues till about 2 years after the final menstrual period. So again, a very sharp bump in this slope of this line, and then lean mass is starting to decline as well, but not as dramatically as that bump in the change in body composition. So let's talk a little bit more about visceral adipose tissue, because I think that this area is kind of a question, and something that observations have been made. Observations have not necessarily all been completely consistent, but I think, again, particularly relative to our conversation today, might be really important. And so this is just looking overall at visceral adipose tissue increase, showing that it's more rapid during the menopause transition, again, compared to 2.5% change per year in the premenopausal years, and about 4.5%, which is still a little bit elevated, changes postmenopausally. This is about a 3+ fold increase during that menopause transition. So this is an increase in visceral adipose tissue. And again, we know that this is the metabolically disconcerting tissue that can have more negative effects from a metabolic standpoint. So trying to figure out why this happens, again, what might be some of these mechanisms? We know that the decline in estrogen concentration is associated with liver synthesis of sex hormone binding globulin. There it is again. And again, this results in higher concentrations of bioavailable testosterone and will actually contribute and predict to the accrual or the buildup of this visceral fat. Insulin resistance associated with slow SHBG might also mediate changes in body composition. The other thing that's really provocative that we've seen more in animal studies than in studies in women is increased FSH. Now, I'm an endocrinologist. I've always thought of FSH as just a marker, something we can measure. If it's high, now we need to look or reassure this woman that she may be menopausal. But in some animal studies, the elevation in FSH actually contributed to an increase in fat mass, a decrease in lean mass, and even a decrease in bone health. So people are looking at this, people are thinking about this, and I think we're going to be hearing more about that in the future. So I wanted to specifically look for just a moment at cardiac fat, and this is something that's come out and I think is very provocative. There's a suggested link between pericardial fat. So this isn't the pericardium, this means next to the heart, pericardial, and here it's shown down here, pericardial fat with menopause and lower estrogen levels. This is independent of age, so it seems to be linked. Greater accumulations during late perimenopause and postmenopause, and links with cardiovascular risk, coronary calcium, and carotid intimal medial thickness. I think the bottom line is we need to learn more about this. We need to learn, how do we monitor it? Do we need to monitor it? Are there any things we can do to therapeutically affect it? But it is a provocative evidence of visceral fat. And then the second area that I wanted to look at, and here's where things are a little bit less well-defined, and that is the question of what's going on with the liver. So compared with premenopausal women, postmenopausal women may be at greater risk of fat deposition in their liver. And I think, as written in the circulation article I originally showed you, that this literature has not been consistent. But I think in recent years, I'm seeing more reports about this. This is non-alcoholic fatty liver disease prevalence becomes similar or surpasses that of men. Women have higher rates of severe fibrosis and mortality. Maybe this is related to estrogen deficiency. In a recent systematic review and meta-analysis, menopausal status was associated with about a 2.5-fold higher odds of having this. And whether hormone therapy will affect this or not is an open question. I've seen some articles about this, but let me just show you some of the hypothesis of how this might evolve. And it's thought that estrogens and healthy living during our youth protect us from this fatty liver. But after menopause, the decline of estrogen, we've talked about some of these other metabolic things that are going on, lifestyle and maybe genetic predisposition would increase the risk, such that we might see that the liver is actually becomes very fatty, and this can be of concern. The reason being that there can be a progression between a healthy liver, a fatty liver, and then an inflamed liver that can, in some circumstances, go on to cirrhosis and even hepatocellular carcinoma. The reason I think we should be really wondering more about how common is this, how do we detect it, when do we see it happen, is because I have questions about how are drugs metabolized in a fatty liver versus a normal liver, and might this be something that we need to be thinking about, particularly when we're thinking about things like pharmacokinetics. So we've talked about a lot of different health changes that can go on during this time. We've talked about changes in lipid factors, mostly going the wrong way, changes in subclinical evidence of atherosclerosis, changes in metabolic syndrome, blood pressure, and looking at some of the important pathophysiology from the standpoint of visceral adipose tissue. So that concludes my remarks. Thank you so much, and I look forward to the questions. Thank you.
Thank you so much, Dr. Stunkel, for that presentation and for highlighting where more research is needed. And I want to thank you for thank all our speakers. So we'll now move into the Q&A session. I recognize that there are a lot of good questions coming in. So my first question is for Dr. Santoro. What are the peak ages and likely duration of the most bothersome menopausal symptoms, and how would that differ among women with natural menopause versus surgical menopause or iatrogenic menopause?
So peak ages on average are going to be that late transition onwards. So the median age is about 49 and tends to be worse in those first 5 to 7 years for most women and then taper. But the median duration of vasomotor symptoms are 7.4 years to be exact from SWAN. And it is very variable. So it's a little hard to predict. You can a little bit on some of the demographics that I said and that Dr. Richard Davis was saying, that some women may have them for much longer. And then there's that small group of women for whom they never go away. And that is a not insignificant group because they will require treatment. Their symptoms can be severe. When menopause is more sudden and surgical menopause, the symptoms tend to be severe and immediate, to the point where many doctors will just actually give a patient an estrogen patch in the operating room on her way to recovery. So she's not drenched in sweat while she's trying to recover from her surgery. Women with premature menopause do seem to also have fairly severe symptoms. So we don't know if that's an interaction of the age at which it happens. One of the other important studies that was done from SWAN was by Pengaja Parmasathi, because she looked at how long each of the transition phases were in women who start earlier. So if your menopause transition starts in your late 30s or early 40s and you begin skipping cycles earlier than average, which is age 47, you're likely to have a longer transition. That longer transition is likely to be more bothersome. So that may also bring you to clinical attention.
Thank you. Our second question is for Dr. Richard Davis. So what additional data are needed to demonstrate the hormonal changes or physiological changes caused by menopause, mainly to changes in PK or PD of the drugs?
I think having larger studies that really drills down to look at those physiological changes. We know that, as I presented, there really is a paucity of data that specifically looks at race and ethnicity and physiological changes. And though SWAN is probably the largest database that we have, it does not necessarily reflect our entire population in terms of race, ethnicity, and regions. And so it's really, from my perspective, critical that we do additional research in that area, but granular.
And I'm sure the second session later on will go into more detail as well. So our third question is for Dr. Strunkel. How does the menopausal transition affect the risk of diabetes? For example, for women with menopause at the usual age, or for women with early or premature menopause?
The question is a good one because there's, I think, some things out there, and in general, the data so far would be somewhat reassuring for women having a natural menopause. We know that diabetes increases with age, but it did not seem that it increased particularly with women going through a natural menopause. So I think we also need to bear in mind if some of those women have metabolic syndrome and sort of a predisposition that they may be more likely to go into to demonstrate diabetes then. There is good data that women with premature or early menopause, be it surgical or natural or induced, are at higher risk of diabetes. So that's the group that we really need to keep a closer eye on.
Thank you. Let me turn back to Dr. Santoro again for the next question. What is the risk of pregnancy during the menopausal transition? And do you think that women volunteer for a clinical study should use contraception?
There is a risk of pregnancy. After age 44, the background risk of pregnancy is about 0.1%. So it's not super high, but it is there. So I like to never say never with that. And if a study is being done where on a drug that may cause problems with the pregnancy, yes, contraception of some sort should be considered. It does not always need to be hormonal contraception.
Thank you. Going next to Dr. Richard Davis. Currently, the impact of menopause on the PK/PD is not routinely evaluated when developing drugs for disease that affect women of various age or in different menopausal stages. Should the impact of menopause on PK safety and efficacy be looked at in development programs for drugs to determine if dose adjustment is needed based on the menopause status?
Yes, that would be a resounding yes. There are lots of factors that influence menopause experience in women. We've talked about race, ethnicity, social determinants, those chronic diseases. And we know that all of those factors stress, for example, can specifically affect the PK. Not to mention, we have an obesity epidemic. And so when we look at physiological distribution of drugs, that's important. And most of our clinical trials, we limit the BMI to 30, maybe 34 is a stretch. But our BMI in this country is increasing dramatically. And so we have to really look at that group as well.
Yeah, let me follow up on that with Dr. Richard Davis. Are there many studies that look at stress levels and correlation between the stress experience and menopause symptoms and the duration?
There are some studies. Dr. Tanae Lewis, who was a SWAN investigator, has looked at that, but she specifically looked at it with regards to the stressors related to race. And so it definitely exacerbates symptoms. And I'll be happy to share that reference if you need it.
Thank you. Next, turning to Dr. Strunkel again. Would you think a bend towards developing diabetes is due to the midsection weight gain associated with menopause and other hormonal factors?
Well, certainly women will identify the midsection weight gain. Even pre-menopausally, they will come in and say, my periods are the same and I'm not having hot flashes, but something is going on. And we'll identify that that has changed. We know that this visceral fat is very active, and there may be some role of that increasing inflammation. And as I mentioned, the lowering of the sex hormone binding globulin with the relative increase in androgen levels or testosterone levels in our body relative to estrogen may also have an effect on that. So the diabetes prevention program studies showed us that if women exercise 30 minutes a day can actually manage to lose 5 to 7% of their weight, not so much, that there was a dramatic 58% reduction of diabetes. That's a pretty good deal. That was better than any medications that they looked at in that study. And there have been other studies, the Healthy Women study out of Pittsburgh, looking at women going through the menopause transition and showing that if they started with an exercise program and mindful eating, that they did not gain weight, they did not have some of these lipid changes, and they didn't, they had a better blood glucose. So if we can bring ourselves to adopt a healthier lifestyle during this transition, everything will be better.
Thank you for ending on that note. So I want to thank you all again, to all of our panelists and to all the attendees for your attention and for the great questions that came in. So I'll now pass on to Dr. Bursoff-Macha again. Thank you all.
Thank you all for such an exciting and informative first session. So we'll now take about a 5-minute break and we will reconvene at 11:35. Welcome back, everyone. And now I'd like to introduce the moderator for our second panel, Dr. Raj Matabushi. Dr. Matabushi has over 15 years of regulatory experience as a pharmacometrics reviewer and clinical pharmacology team lead in the Office of Clinical Pharmacology in the Center for Drug Evaluation and Research at FDA. He currently serves as the Associate Director of Guidance and Scientific Policy in the immediate Office of Clinical Pharmacology. Dr. Matabushi is the CEDAR point of contact for the Mid-Paired Meeting Program. And Dr. Matabushi is also involved in global harmonization activities as the rapporteur for the ICH M12 Expert Working Group, Drug Interaction Studies. Welcome, Dr. Matabushi.
Thank you, Dr. Bursoff-Macha. I'm very pleased to introduce the next session, Menopause and its implications on pharmacokinetics and pharmacodynamics. Before we get started, I would like to remind participants to type their questions for our speakers in the Q&A function, and we will address questions at the end of this panel. Again, the views and opinions expressed in the following presentations represent those of the presenter and do not necessarily represent an official FDA position. Now, I would like to introduce our first speaker, Dr. Leslie Bennett. Dr. Bennett is a professor and the former chair of the Department of Bioengineering and Therapeutic Sciences in the Schools of Pharmacy and Medicine at University of California, San Francisco. He is among the most highly cited pharmacologists. He was founder, president of the American Association of Pharmaceutical Scientists and elected to the National Academy of Medicine in 1987. He chaired the FDA's Center for Biologics Evaluation and Research Peer Review Committee and expert panel on individual bioequivalence, serving on the initial FDA Science Board and Generic Drugs Advisory Committee. Dr. Bennett will be setting the stage for discussion about the effects of menopause on the pharmacokinetics and pharmacodynamics of drugs. Welcome, Dr. Bennett.
Thank you, Raj. And FDA is controlling bringing my slides up, so. No, do I need to share? Okay, I'll share. Whoops, okay, there they are. Thank you. So I'm happy to talk about this topic. It's a topic I spent some time on last century and was pleased to have the opportunity to review what was going on today. So my slides are not going forward. So FDA is controlling. Can you move? Okay. So my conflict of interest is I chair the board of directors of Medicines 360, a nonprofit drug company, and we have a product approved by the FDA. We had a recent improvement in approval in July of 2023 for heavy menstrual bleeding. But at this point, I have no products. We have no products being evaluated by the FDA. Next slide. So let me go on topic history. Next slide. So in 30 years and 6 months ago, I spoke at the NIH workshop on menopause. The title of my talk was Menopause, Pharmacokinetics, and Pharmacodynamics. Next click. And we published that study, or the review, in 1994 in Experimental Gerontology. Next click. And we concluded that the effects of menopause on pharmacokinetics and pharmacodynamics remain largely uninvestigated. Next click. In summarizing directions for future research, we noted that although several studies have examined the effects of estrogen replacement in postmenopausal women on the pharmacokinetics of certain drugs, questions regarding pharmacokinetic differences between pre- and postmenopausal women generally remain to be studied. Click. Unfortunately, today, 30 years later, my review is not much different. Next slide. Next click. A number of hormonal hypotheses were considered in the 1990s, but subsequent experimental data evaluating these hypotheses present conflicting results, and there's still a great uncertainty about the potential of measurable hormonal explanations. Next. Since that time, a number of papers have been published purporting to identify menopause versus aging effects, but I find that many of these papers are not trustworthy, and if I had been the reviewer, would have recommended rejection. And there are trustworthy papers, but they appear not to be translatable to general principles. Next click. One of the most informative papers was this paper by Lemons et al. In 1990. Looking at the influence of age on the pharmacokinetics of alfentanil. And when you look at the females in terms of clearance, which is a measure of the body's ability to eliminate the drug, you can see in the solid circles an obvious decrease, significant decrease with age. But when you look at the men in the open circles, you don't see this relationship. Next click. So these authors stated that there was approximately 60% of the variability of alfentanil clearance was explained by age in women, and concluded that the effects of age on alfentanil clearance were gender dependent. Next click. This data was reviewed and published the next year by Rubio and Cox, who reanalyzed the data and assumed that all women 46 years and younger were premenopausal, and all women 55 years and older were postmenopausal. And when they did that, they found that 2/3 of the variation in alfentanil clearance in females appeared to be explained by menopausal status. Next click. So here's that data, where you can see versus the premenopausal on the left-hand side, the postmenopausal on the right-hand side, and there's hardly any overlap, with the presumed premenopausal clearance of 24.6 liters per hour falling in half to 13.7 in the older presumed postmenopausal women. Lemons, in a response, confirmed that none of the women were receiving estrogen replacement, but did not know the menopausal status of the subject. We propose, looking at this data, that the results could be explained by drug metabolizing enzymes being sensitive to concentrations of hormonal levels. Next click. And so in this paper that we published in 1986, what we did was look at prednisolone, unbound and total clearance in young control women, B, you can see their clearance, unbound clearance 10.2, oral contraceptive users where we have compounds with ethynyl groups that actually can knock out the cytochrome P450 3A enzyme, clearance almost going down 2/3, versus the postmenopausal control women, D, 7.74, significantly different than the young control women. And then conjugated estrogen users in the age group also, even a further slight decrease. Next slide. So when we compared this value, we saw the decrease in clearance and the increase in half-life as a function of the menopausal status. And the difference could be due to estrogenic or progestogenic effects on the components of oral contraceptives. However, we pointed out that you must also consider that 17-alpha ethynyl side chain can destroy the metabolic capability of cytochrome P450 enzyme, and that's what's probably happening with the birth control younger women. Next slide, next click. So we compared the data in the young and the controlled and basically said we could see these effects, but the question are these changes due to age or are they due to hormonal differences? Estrogen replacement therapy did not return the pharmacokinetic parameters to premenopausal levels, and in fact, an opposite effect. But we noted also that the replacement conjugated estrogens were formulated with natural non-ethynyl estrogens. Next click. So the effect of estrogen replacement on the pharmacokinetics of other drugs gave conflicting results when we did our review in 1994. Significantly higher plasma concentrations of a phenothiazine antipsychotic, butyperazine, were found in postmenopausal female patients receiving conjugated estrogens for 7 days. Next click. But clearance of diazepam was impaired in women taking conjugated estrogens when compared to age and weight matched control women. But in the same study, there was no effect on lorazepam nor alprazolam. No effect of conjugated estrogen in postmenopausal women was observed in the pharmacokinetics of antipyrine, oxyprozine, and acetaminophen. We noted that none of these early studies have examined the effects of the replacement of both estrogen and progestin, and none of these early studies compared premenopausal and postmenopausal women. Next click. So after our 1994 review, we continued to carry out some studies. Next click. So in this Harris et al. Study, the effects of menopause and hormone replacement therapy on prednisolone and erythromycin pharmacokinetics. Next slide, next click. What we can see is the premenopausal clearance, 2.59, the postmenopausal clearance, 1.84, a significant decrease. Also, we see the difference when we look at unbound drug. And then we looked at estrogen and estrogen plus progestin, and we really didn't see a change in postmenopausal. Now, we also looked at erythromycin kinetics in these studies, and we used the erythromycin breath test. In this study, we actually saw no change in erythromycin. In the next study I'm going to show you, we did see a change in erythromycin. Next click. But in fact, right now, we don't really believe anymore that the erythromycin breath test was quantitatively accurate. And so really our data only relates to prednisolone. And I would not say that we could say that the erythromycin data is coincident with the prednisolone data. Next click. Next click. So we also looked at the evaluation of progestins as inducers of cytochrome P450 activity in postmenopausal women in this paper in 1998. Next click. And basically, we looked at control women giving IM progestin or giving oral progestin, and then for 2 months, and basically saw no change in the kinetics. Next click. So no meaningful effect of progestin dosing in postmenopausal women in terms of prednisolone clearance. Next click. Next click. Here's another study not in our laboratory, Fleischaker et al., hormonal effects of terilizad clearance in women, assessment of the role of cytochrome P450-3A. Next click. In this data, looking at premenopausal women in terms of the clearance of terilizad, 0.51, postmenopausal 0.34, a significant decrease, adding estrogens or adding estrogen plus progestin, really no change in the postmenopausal women. And they also ran another CYP3A4 drug, midazolam, and also showed the same effect. Significant decrease in clearance postmenopausal with really no effect of adding estrogen or progestin. Next click. So clearance of terilizad was significantly decreased and unaffected by estrogen and progestin. Next click. And similar results were also observed with the CYP3A substrate midazolam. Next click. Here's another study by Gorski et al. Now, this is actually looking at midazolam clearance, young women with no estrogen replacement, elderly women with no estrogen replacement, and elderly women with estrogen replacement. Now, clearance goes down, and you see it from the intravenous doses, and you see actually really no significant change with the oral doses. But in contrast, this data was not significant. And this is sort of the characteristics of all the data we have out there. Next click. Sometimes it's significant, sometimes it's not significant. Next click. Next click. Here's an interesting study, the effects of gender and menopause on serum lidocaine level in smokers. Well, lidocaine is a drug primarily eliminated by CYP3A4 with some CYP1A2. And so they carried out this study in smokers because you would get an increase in 1A2 in smokers. But it's not good pharmacokinetics. Lidocaine is a high clearance drug. So it's rate limited by hepatic blood flow. So in fact, this study doesn't look at the metabolism at all. The drug's eliminated by metabolism, but it's rate limited by hepatic blood flow. So this study, in fact, all it shows is that hepatic blood flow is not different when it's dosed on a weight basis to men, premenopausal women or postmenopausal women. And even though this is in the literature, there's really no results here that tells you what happens in drug pharmacokinetics and pharmacodynamics as a function of menopause. Next click. So my conclusion on the effects of menopause on metabolic drug elimination, next click. So it appears that a number of drugs that are eliminated significantly slower in postmenopausal versus in postmenopausal women by metabolic processes. And most of the data where you see this effect is drugs eliminated by CYP3A, and that's important because when drugs are eliminated by metabolism, half of them are eliminated by CYP3A. But these studies are limited and not completely convinced that menopause actually does the change. There's too few data. So we need more male-female versus age studies need to be carried out. But that's also going to be questionable because if I look at male-female, I'm assuming that sex doesn't have an effect on clearance, and I'm only looking at age, and that may not be true. So the one and only finding over the past 30 years that I'm convinced is true is that supplemental dosing of estrogen and progestin to postmenopausal women does not reverse the decreased clearance observed. Next click. So what about transporters? Because we've looked at enzymes in terms of elimination. What about transporters in terms of elimination? Drugs that are primarily not eliminated by metabolism like rosuvastatin, or a drug like docetaxel that both has transporter effects and enzyme effects. Next click. So there are two studies that are referenced on rosuvastatin in looking at males versus females and premenopausal versus postmenopausal women on rosuvastatin. But these studies are completely I would have turned both of these studies down. The studies are not scientifically valid, and I don't consider that any of the findings related to menopause are trustworthy or is useful. And this is one of the major problems. We really don't have good studies. Next clip. So there are some studies, though, that show the effect on transporters of hormonals. So testosterone in this Grubb et al. Study is shown to inhibit a hepatic uptake transporter, OATP2B1, and in gut transporter, and reduces hepatocyte uptake of rosuvastatin. Shitara et al., it's a study from the Sugiyama lab in Tokyo, show that efflux transporters, P-glycoprotein, MDR1, BCRP, which is also a major efflux transporter at MRP, that all of those involved in biliary excretion of rosuvastatin are inhibited by female hormones. And then another study by Wang et al. In 2006 that showed that estrogens lower these efflux transporters, BCRP and MRP2 expression. Next click. So next click. Next. So here's a very interesting study that I don't know what to do about. This is a study looking at P-glycoprotein, ACB, what they call B, looking at polymorphism on docetaxel pharmacokinetics in menopausal status, including in breast cancer patients. So if you look on the left-hand side, you're looking at premenopausal women. So we could look at the heterogeneity of this transporter. And we could look at the wild type TT, or we could look at the heterozygote CT versus the CC, which is the change. And in premenopausal women, you see a significant decrease. But when you look at postmenopausal women, it disappears. Next click. Next click. Next click. So here's another study looking at docetaxel. Now, this is not looking at the transporters. This is looking at the metabolism of docetaxel, which is CYP3A, in Japanese female breast cancer patients by using population modeling approach. So the population pharmacokinetic parameters of docetaxel in Japanese female patients with breast cancer showed clearance was higher in the postmenopausal women over 58 years of age, than those younger. Docetaxel is, although it's a substrate for transporter and can be rate limited, it is metabolized by CYP3A4. But note that these results are the opposite of what we saw with all of the studies when I was looking at metabolism of CYP3A substrates, where the CYP3A metabolism went down. This is showing the CYP3A metabolism going up. They also looked at another drug, paclitaxel, which is eliminated by another enzyme, CYP2C8, and they saw no effects on menopause or premenopausal, menopause versus postmenopausal. Next click. So my conclusion on the effects of menopause and elimination of rosuvastatin and docetaxel, next click. I have no idea as to the recommendations concerning dosing of rosuvastatin or docetaxel in postmenopausal women. I'm certainly not going to look at a genetic transporter effect. When effect, I don't even see any difference in the one study published. And overall, the conclusions from my talk, there is a dearth of reliable studies of pharmacokinetics and pharmacodynamics in menopause. The situation today is not much different than 30 years ago. And until quality studies address this problem, I have no reasonable recommendations to make concerning what is going to happen in menopause. I do believe that there are some relatively good studies that show a decrease in CYP3A, and this may be the reason, but there's also studies showing there is no effect of CYP3A, and there's studies showing that it goes in the opposite direction in docetaxel. So we need good studies, and thank you for giving me the opportunity to once again review this data.
Thank you very much, Dr. Bennett, for that very informative presentation about the effects of menopause on PKPD and reviewing the current literature and the history. Our next speaker, Dr. Virginia Miller, is a professor emerita of surgery and Physiology at the Mayo Clinic in Rochester, Minnesota. Her research focused on how sex steroids and conditions unique to women, such as pregnancy and menopause, affect cardiovascular health and cognition. She was the principal investigator of the Mayo Clinic Specialized Center of Research on Sex Differences and directed their Women's Health Research Center. She has also served on review and editorial panels and in leadership positions for professional societies. Welcome, Dr. Miller.
Thank you very much. And as I get my slides up here, I'd like to thank the organizers for inviting me to participate in this conference, which I've found very interesting, what I've heard so far. And I can tell you that you may be hearing some of the same things from me, and hopefully in the speakers following, because there's a common theme that we need more data. So let's get started. I don't have anything to disclose in terms of financial conflicts of interest, but I will say that my conflict of interest is intellectual, and that I would really hope that some of this information that we're putting forward today ends up with viable new studies. So first of all, I'd like to review for you how sex steroids affect cellular processes, because I think in order for us to make advances, we need to go back to the basics and understand the physiology. We need to look at what the differentiation of the sex steroids versus the aging process and the influence of one and the other, and then talk about pharmacogenomics and drug responses. And then finally, where do we go from here? So let's remind ourselves that when we look at cellular function, that the genomic regulation of the cell is driven by the sex chromosomes, the sex chromosome effect, which happens at conception. Whether there's XX complement or XY complement affects the cellular metabolism independent of whether or not there are hormones on board. And we need to keep this in mind when we look at sex differences between drug responses. Now, of course, on top of that are the interaction or the effects of the sex steroids, all of which can affect surface ion channels, they can affect gene transcription. We call this non-genomic regulation or activational when we have the cellular receptors or the membrane receptors affecting signaling. And we've heard nitric oxide mentioned. Indeed, estrogen regulates nitric oxide synthase activity and production of nitric oxide, which is protective against cardiovascular disease. And many of these immediate effects or these activational effects, that is, they're present when the hormone is there and gone when the hormone is not, can interact with the gene transcription. So when we think about the cellular interaction of what's going on with the hormones, we need to keep in mind that there are activational effects, the effects when the hormones are there or when they're gone. So what does this mean in terms of aging? Well, we know that the sex steroids are produced from testosterone. They increase over the puberty. Estrogen is derived from testosterone, so we need to keep in mind that particular enzyme in terms of activity, and both decrease with aging processes. So what does this mean in terms of effects on vascular health and disease? And Dr. Santoro already mentioned this study by my colleague Walter Roca, where he looked at the women in the Rochester Epidemiology Project of 18 conditions of premature aging as defined by the Public Health Service. And in this group, we had women who had their ovaries removed prior to the age of 45, compared to referent, about twice as many referent women who retained their ovaries. And as you can see, there's a variety of conditions which increase with aging, and early removal of the ovaries prior to the age of menopause increased the rate of expression of all these diseases, every one of these 18 conditions of premature aging. And as Dr. Santoro already mentioned, although there's been a lot of emphasis on estrogen, you can keep in mind that removal of the ovaries affects other hormones besides estrogen and progestin. And as she mentioned those prior to. The thing to keep in mind is when you look at, think of in the real world, what do women take drugs for? There's a lot of women as they age take drugs for depression and anxiety and so on, where there's potential for these effects of the absence of the hormones to really affect their overall health. Cardiovascular disease, asthma, chronic kidney disease, osteoporosis, of course, that was discussed quite elegantly by Dr. Stuckel. and chronic pulmonary disease. So when we think of drug responses, keep in mind that we're talking about the pharmacodynamics, what the drug does to the body, but also importantly, what the body does to the drug in terms of absorption, distribution, metabolism, and initiation and elimination. Hormones have the potential to affect all of these, not just one, but all of them. Let's see how that might be. So if we look at where sex steroid hormones may interact with drug reactions, we heard from the previous speaker that they can compete or affect transporter activity. They can interact with the same receptor that the estrogen might be binding to. They might affect enzyme activity and also alter gene transcription. So when we think about a drug and where it's going to potentially be influenced by a hormone or estrogen or progesterone or even testosterone, it may not just be at one part here. The interaction of the hormones may affect the transporter, but it also may affect the enzyme activity as well as the gene transcription. So it's isolating one of these effects along the way may not give us a complete picture of the effects of the interaction of the hormones on drug metabolism. So let's take, for an example, one common drug, which are the statins. And these open circles here, the purple, are the drugs and the possible way these drugs are metabolized. And you can see there's more than one enzyme involved in these metabolisms and elimination. Now, the estrogen, although it says here it's going to be green, is going to come in as yellow. And so we can see it goes into the intestines, it's metabolized, it may enter the liver through the blood and interact with all of these enzymes that metabolize, again, the transporter here that affect, affect the metabolism of these various statins. So how can we really isolate one of these things to see, how the metabolism is going to be affected? Because you can consider that in any single woman, there may be not only genetic variations in the enzymes, the genes that control these enzymes activity, but also the genes that regulate the transporters, the receptors, and also the metabolism of estrogen itself. And if we think of the common drug reactions, then this is from 2014. I'm sorry, I tried to find an updated version. I couldn't, but you get the picture. Of the adverse drug reactions that are common among the population, the pink represents those that are just shown by women. And as you can see, these adverse effects of drugs are more prominent in women compared to men. Now, again, I don't know what the the age distribution of these women were, or their hormonal status, but that the general picture is that there are more adverse events reported in women compared to men. Is that because there's differences in drug metabolism? And indeed there are. There are differences in the medications that are used, the body sizes, the organ size, the tissue composition, and we heard about lean body mass and body fat, gastric secretion, emptying time, protein binding, immunology, and drug metabolizing enzymes. So when we try to identify what the impact of these are on the pharmacodynamics and kinetics, we have to consider that we're dealing with differences in all of these things, and all of these can contribute to the efficacy of the drug. And many of these differences can be attributed to hormones. Some enzymes which are indicated to have higher activity in men compared to women are the CYP2D6, C12, 1A2, and some conjugating enzymes, and the activity that some is higher in women is CYP3A4. And these have been documented in other studies. Now, again, whether this is true for women as they pass into menopause, big question. So we don't know whether these changes are contributing or partly due to changes in the genetic changes as well. or natural changes. And I love this slide, which was published quite a few years ago by folks at the FDA, where they've looked at rats at different ages, and each one of these animals is represented by a circle. And you can see there's a big dichotomy of how these enzyme activity changes over time. And this is just one enzyme, right? This is the female response with aging. And this is the male. So you can see that there are changes related to aging in these animal studies. Unfortunately, we don't have similar data in humans, and that makes sense because it would be very difficult to do a longitudinal study to analyze these types of data. But there's a lot of information that the enzyme activity in animal studies differs between males and females, and that needs to be taken into account when we think about the efficacy and side effects of drugs which are being developed today. So what do we mean by a pharmacogenomic effect? That means that the genetic SNP influences, a genetic variant or the SNP, influence the effect of the treatment on the outcome. So what actually does that mean? That means, for example, if we give a drug and it's metabolized, and we're going to look at estrogen metabolism, the genetic modulation in any of these enzymes is going to affect whether or not that hormone might be effective because of whether it's metabolized or changed or sulfonated or oxidized or whatever. So we looked in the KEEP study with Dick Winchenbaum and Ann Moyer at the genetic variation of the sulfonated enzymes, which take estrone to estrone sulfate, estradiol to estradiol sulfate, to see whether this genetic variation affected the efficacy of hormone treatments. And I also want to mention too here, we have to be careful when we talk about hormone replacement. We've heard about using conjugated equine estrogen, which is a combination of many of these metabolites of 17-beta estradiol, mostly estrone and estrone sulfate. So any use of oral transdermal 17-beta estradiol may not be directly comparable to results obtained with CEE or conjugated equine estrogen. But let's look what happened at the genetic variants of this particular enzyme, which sulfonates estrogens. Well, to begin with, we have to understand that there can be a variation and deletion of one of the alleles, but there's also differences in the copy numbers of the genes. So it may not just have one copy of the variant, it may have two, or it may have as many as 3 or 4. Does this impact anything on health or outcome in menopausal women? We looked at the onset of menopause in the KEEP study with Dr. Moyer, and she found that the number of alleles of G alleles of this particular SNP on the gene that regulates the enzyme affected the age at which natural menopause occurred. So if there were no low copy numbers or none, the age of menopause was higher. But if there were a lot of numbers of the copy of this particular allele, menopause started at a very early age and was significantly different. So the metabolism of estrogen to the sulfonated form affected the onset of menopause. The onset of menopause, or the change in the bioavailability of the estrogen, is going to affect all these other cellular processes. And as you can see, with removal of the estrogen with early oophorectomy, increased the rate of chronic diseases, that this indeed would affect the aging process in these women. We also looked at the effects of the hormone treatments, either conjugated equine estrogen or 17-beta estradiol, and the deposition of beta amyloid in the brain. And we found that in the women that had were carriers for the ApoE epsilon 4 carriers, which increases the risk of amyloid deposition in women, that those that were on 17-beta estradiol had less deposition of the amyloid compared to referent women, and was significantly different from those that were on the conjugated equine estrogen. So again, here the estrogen matters, and this particular allele affected the beta deposition. Now, why is this kind of interesting? Well, it's kind of interesting to me is that there's been lately a drug approved to reduce the amyloid in the brain associated with Alzheimer's disease, which showed in the data that I reviewed less efficacy in women compared to men. But they also saw an effect of the ApoE carriers. But when we looked at the data, I could not find how many of the proportion of those women were the ApoE carriers. So this is an important thing to keep in mind when we're looking at effects of the drugs and trying to differentiate the effects of men versus women. And then you're looking at genetic variants. You also have to know where that genetic variant is most prevalent. Is it in the men or is it in the women? And does that affect the outcome of the drug? And of course, if we looked at those were non-carriers, there was similar effects in both of the groups. This was work done by my colleague Kajal Kantarsi at Mayo. And all of this work was supported by the grants from NIH, including the Specialized Center of Research Excellence on Sex Differences. There was also some suggestion in the paper related to the drug for amyloid deposition in the brain, that it was less effective in African-American women, and the authors concluded that there may be other underlying causes of conditions preceding early cognitive decline or Alzheimer's disease. So I showed these data to emphasize from work we did with Julia Fields at Mayo, looking at the effects of pregnancy preeclampsia on brain damage in early menopausal women. And these red areas shows the degree of damage in areas associated with visual spatial function in women that had a history of preeclamptic pregnancies as they went into menopause. So, and we used here clinical consensus and diagnosis of cognitive status, which is a combination of conditions which actually proved to be more reliable than actual scores on testing and self-report. So indeed, there is other underlying conditions which may affect the efficacy of a drug or the demonstration of a disease, and pregnancy history is an important component of those things to age. So I was talking about genetic variants in drugs that metabolize, enzymes that metabolize drugs, and CYP2D6 is one that there's a lot of literature on genetic variations of this drug and drug metabolism. So these are my data. I participated in a study at Mayo, the Right 10K study several years ago that was looking at sex differences and risk for statins. So my participation resulted in this genetic analysis of several of my enzymes, and plus 9 more. I'm not going to bore you with all of them because, to me, I don't understand many of them as well. But here are the data, and here's the interpretation. And the interpretation goes on and on. It says, predicted an intermediate to an extensive normal. I don't know how those two words go together, but metabolizer. And it says, some caution should be exercised when treating with drugs metabolized by CYP2D6. Now, if you read that as a clinician, what does that tell you? Does that tell you anything? To me, when I interacted with the medical profession a lot recently for some issues that I've had, and when the anesthesiologist comes in, I said, I don't do drugs well. And I say, I have this genetic genotype, CYP2D6, and I said, I just don't do well. And they seem to shake their head and understand. Some eyes glaze over. But this information that would come with an interpretation of a genotype that would affect drug metabolism needs to really be user-friendly for the medical profession to be able to make recommendations, because CYP2D6 metabolizes a lot of drugs. So when we think about research design, how can we actually go forward? Well, we need to think about age for sure, ethnicity and relationship to genotypes, hormonal status, reproductive history, and these are things that should be in the medical record, but usually some to varying degrees. And if the individual is using hormones, we need to be aware that there's different types that are metabolized different, mode of delivery, ones that go through first pass of the liver, oral, compared to those transdermal, whether we're suppressing endogenous hormone levels or removing them, whether they're synthetic or natural formulations, the duration of treatment, concomitant treatments and underlying conditions which may interact with the drug, and of course, compliance. Reproductive history, as I mentioned before, a history of preeclampsia, number of spontaneous abortions, and gestational diabetes are things that may affect a woman's response to drugs or risk of conditions going forward. So where do we go from here? I have 4 recommendations. First of all, I think we need more data on the sex and ethnic differences in the etiology and mechanisms of disease. If we don't understand what's going on basically in the basic physiology, we're starting from an unknown place. And we need more studies on how development of type 2 diabetes and the type and distribution of adipose tissue affect drug dynamics. This has been mentioned in previous talks, and I would just emphasize that when we look at adipose tissue distribution compared to abdominal versus those more in the hip and buttock areas, that this is going to affect distribution of drugs and metabolism. And there's work from Wendy Kort's lab out of the University of Colorado that the type of adipose tissue that develops in women in the abdominal region in menopause does not metabolize, has metabolic differences compared to fat that was their abdominal fat prior to menopause. And we need to understand that more. And if you look at all the type 2 diabetic drugs that are advertised on television, there's a slew of side effects, And my question is, are these more in men or more in women? And, where are those data that we can actually take a look at it and know? Studies are needed to identify the impact of genetic variants on drug metabolizing drugs by age, sex, and ethnicity. Just doing genetic variants in a variety of populations was not all knowing the sex and age and even hormonal status is not going to get us anywhere. And we need a better way to utilize genomic data in the prescribing practice. Here may be a place for artificial intelligence to be able to be mined to use these data to come up with reasonable recommendations. But we also have to educate physicians on how to use them. Because in my various discussions with my anesthesia colleagues over the course of my career, they hear about this, but it's not really put into practical terms. And somebody would say, well, I kind of heard about it, but don't know how to use it. And what does it mean? So we really need to start educating the medical community in terms of how genomics actually affects progression of disease, but also treatment. And finally, I can't emphasize enough the need to report data for safety and efficacy trials by sex, age, and ethnicity. And not just look at the age effect, but the age efficacy by drug, by sex, and ethnicity, in order to give us meaningful data to know who is more at risk and who is more likely to benefit from a particular medication. So my recommendation is if we pay more attention to these 4 things going forward, that we indeed can improve the health of women and the safety of drugs that they use to treat their diseases in the future. Thank you very much for your attention.
Thank you very much, Dr. Miller, for that insightful presentation on both the pharmacokinetics, pharmacodynamics, and the recommendations. Now we will take a quick 5 minutes break and we'll be back at 12:28. Welcome back, everyone. We will now continue with the session 2 panel presentations. I would now like to introduce Dr. Audrey Gassman. Dr. Gassman is the Deputy Director of the Division of Urology, Obstetrics, and Gynecology at FDA. Throughout her FDA tenure, she has worked on numerous drug development programs and led several guidances through development. Dr. Gassman is board certified in obstetrics, gynecology, and reproductive endocrinology. After receiving her medical degree, she completed an obstetrics gynecology residency and reproductive endocrinology fellowship. She practiced and taught for 7 years before joining the FDA. Welcome, Dr. Gassman.
Thank you very much, Dr. Matabushi. I believe you're showing my slides. Thank you. So I'd like to start by saying that the focus of my presentation is based on my experience as someone who has done an overview and reviewed data and results from clinical trials. And the clinical trials that I'm specifically referring to are those trials and studies that test potential treatments from volunteers to see if the drug, device, or biologic product can be approved for use in the United States for use in the general population. Next. I have nothing to disclose, and I just want to point out that my presentation is not intended to convey any official policy. Next. So today, I'm going to talk about some of the opportunities and challenges when assessing menopausal females in clinical trials, and specifically for clinical trials that are intended to support safe and effective use for approval in the United States. Next. So my talk is going to focus on 3 areas. I'm going to do a very brief clinical background of menopause, and I'm going to do that because in clinical trials, because they are a very short window of time, defining the population is extremely important. I'm also going to talk about some of the challenges in recruiting menopausal females for drug development, and then I'm going to finally talk about some opportunities from an FDA perspective to address these challenges. Next. So, as I mentioned, defining condition is very, very important for a clinical trial because you want to make sure that you are studying the population of interest. So from looking at this from a global view, menopause is usually defined as the lack of estrogen production by the ovaries that results in the cessation of menstruation or after ovarian removal. The menopausal transition is the years leading up to that point when changes in the monthly cycle and hot flashes and other symptoms, which is also called the perimenopause. And the transition most often is between 45 and 55, but as has been discussed by other speakers, it's variable. It seems to have other components to it, and it may be as long as 14 years. There is also a clear postmenopausal period, which is the time after menopause, and it usually starts approximately 1 year of no menses or after ovarian removal. Next. So much of the available information about the endocrine and clinical manifestations of the menopause and menopausal transition comes from a variety of studies. I'm going to highlight one of the largest and current, which is has been mentioned before by Dr. Santoro and Richard Davis, the study of women's health across the nation, or SWAN, which followed a multi-ethnic community-based cohort of over 3,000 women, ages 42 to 52 for 15 years. And based on data from these studies, a staging system, which has been shown before, called the STRAW criteria, has been developed and is considered a gold clinical standard for characterizing reproductive aging from the reproductive years through menopause. Next slide. I also want to point out that the age at menopause has remained constant, although life expectancy has generally increased. And when you think about this, 984 million women in 2020 reached menopause, and that's about 6,000 women daily, and more than 2 million women yearly reach menopause. And women spend up to 1/3 of their lives, and worldwide this is 1.2 billion by 2030. So women spend a large amount of time, and with a life expectancy of about 81, and this means that they represent a very clinically important subgroup that needs to be carefully studied depending on the chronic condition or disease treatment that is under study. Next. So one of the issues is menopausal symptoms versus what are those that are related to aging. Now, it's very clear that some symptoms and conditions are very clearly related to declining estrogen, and I'm not providing a complete list, but hot flashes, vaginal dryness and discomfort with sexual intercourse, and osteoporosis are very clearly related to declining estrogen. But in the menopausal transition, many chronic conditions become more prevalent, such as hypertension. And up to now, we really don't have a lot of studies trying to assess to what degree menopause exacerbates these conditions, or whether menopause impacts the treatment response. And in fact, even when evaluating the PK of products that are used in women, such as tamoxifen, there was a recent study by Bacha in Biology that talked about cofactors of age and BMI and medication adherence. And although the authors noted that menopausal status is important, they didn't reference any specific publications that had looked at the transition of menopause on tamoxifen pharmacokinetics. Next. So as someone who was a gynecologist and someone who is now on the regulatory side, I've watched development of new therapies for a variety of menopausal symptoms, but the availability of safe and effective drugs impacts the lives of women across the spectrum. I think looking to the decade ahead, there are many opportunities that hold the potential to really transform clinical trials to better capture and assess data on the menopausal transition and through the menopause to postmenopause to improve their lives. And I see that this is an important time where collaboration and scientific advancement needs to propel this field. Next. So let's start with some of the challenges. Next. So if you go back and look at historic clinical trials that are intended for drug, and by drug, I'm also talking about development of biologics such as vaccines and blood products and also devices, there's not routine capture of serum FSH levels or detailed gynecologic history unless the product was specifically indicated for use in postmenopausal females for symptoms. There's no standardization of the definition of menopause in many trials, and it also may not even capture the time the woman has been in menopause. Serum FSH, which has been the gold standard for menopause diagnosis, really only identifies women who are in the postmenopausal period. So it's very limited even as an individual biomarker. And in looking at PK/PD studies for most drug development programs, they usually only include a small number of female subjects, and these subjects could range from the reproductive age through menopause. Next. And when we look at current clinical trials, trials can be limited because there's a lack of dose finding in female cohorts. There may be a lack of sufficient enrollment to pre-specify and to assess menopausal status as a subgroup. There's questions on how to factor in use of hormonal therapies or supplements if they're allowed. And there's also additional need of gynecologic subject matter experts and other laboratory assessments. And sometimes those laboratory assessments, given that until very recently we did not really have appropriate staging, was very difficult. Next. And then there's also limited published information on how to optimize recruitment of menopausal females into trials. And just to give you some examples, menopausal females may be caretakers for older parents, relatives, grandchildren, which may preclude trial participation or require that visits be conducted outside usual business hours for clinical trial sites. Assessing menopausal females may require additional gynecologic or women's health care services, which may not be available at a standard clinical trial site. And under-enrollment of menopausal and other females may represent a lack of patient or family-centered discussion around the benefits of trial participation. Next. So FDA is very supportive of innovations to improve recruitment and evaluate menopausal females in clinical trials. Next. So now I'm going to talk about some of the FDA efforts to improve inclusion and diversity in clinical trials, because clinical trials provide the crucial base of evidence for evaluating a medicine product, whether it be a drug, device, or biologic, and its safety and effectiveness. And it's important that clinical trials evaluate and reflect the diversity of the population that's going to use the treatment. So the FDA has issued guidance, including the 3 guidances that I mentioned above, to try to include approaches sponsors can consider when they're trying to enroll populations in their clinical trial, and also recommendations to provide standardized approaches for collecting and reporting race and ethnicity in clinical trials. So CEDAR also shares the information sharing with the outside world, and we do have a mechanism called drug trial snapshots, which I want to point out, which is an effort to make demographic data from clinical trials for approved products more available and transparent, and I provided a link in my slides. And in addition, we're trying to facilitate the use of innovative clinical trial design and clinical trial assessment through decentralized trials, use of digital health technologies, broader inclusion of clinical trials, use of real-world evidence. And in thinking about the vision of improving enrollment of menopausal females as a subgroup, I think these types of innovations will help support better and more inclusive clinical trial design. Next. So FDA also is involved in advancing regulatory science to improve enrollment of the diverse populations. And we have both extramural research, which is partnering with outside the FDA, and I'm going to speak about the broad agency announcement and Center for Excellence in Regulatory Science, or CERSI. And then I'm going to talk about some partnerships. So since 2012, we've had a contract mechanism called the Broad Agency Announcement, and I'm going to call it BAA. And BAA makes it possible for us to solicit innovative ideas and approaches to evaluating FDA's regulated products. And by tapping into external knowledge and infrastructure where the FDA has very limited expertise, we can invite proposals from industry, academics, and other agencies to help us better understand the innovative scientific and technological solutions to some of these difficult regulatory science problems. In addition, CIRSE is another robust, innovative approach where we partner with the CIRSE program to facilitate interaction of FDA experts with outside stakeholders to promote cutting-edge scientific research. And this can occur through workshops and scholarships and fellowships and competitions. We also have partnerships outside that enhance science through collaborations of the FDA with both government, such as the CDC and NIH and other groups. Next. So as well as the extramural research, which is the BAA and other programs, excuse me, we also have internal programs or intramural research, one of which is called the Oak Ridge Institute for Science and Education, or ORISE Fellowship Program. And this is a program where external fellows who are college students and those with advanced degrees can come to the FDA in a learning program to help learn about how FDA does research and assist us with working on our scientific research projects. And these are conducted through mentor-led research regulatory projects. We also have a drug development tool grant program that's a targeted support for research of drug development tools that advance the field. And there are many other collaborations, such as a memorandum of understanding with other agencies and other programs, and details on these programs can be found at the links through my slides. Next. So I think it's very clear, and I think all the speakers today would likely agree with me, that we need more research into better methods of communicating new and ongoing research projects and clinical trials to menopausal women. And we need to broaden the knowledge of research and recruitment of gynecologists and providers so that they're aware of these studies, and hopefully they can help us improve enrollment into clinical trials. And perhaps we need to consider how we can better target community outreach to let them know the importance of participation in these clinical trials so that we can get better data. Next. So in summary, I think there's a great potential now to advance health outcomes for menopausal and postmenopausal females beyond symptom control. And FDA is working to facilitate and encourage innovation. And I think that collaboration and research are the keys to advancing the common goal of delivering more safe and effective drugs for more patients more efficiently. And I'd like to thank Christy Chang and Jana Comstock. Thank you, and that concludes my presentation.
Thank you very much, Dr. Gassman, for that overview on the opportunities and challenges when conducting clinical studies in menopausal and postmenopausal females. Now, I would like to introduce our final speaker, Dr. Yanwei Liu. Dr. Liu is the clinical pharmacology team leader supporting the review of urology, obstetrics, and gynecology drug products at FDA. Dr. Liu received her PhD in pharmacology and molecular sciences from the Johns Hopkins University School of Medicine. She started her career as a senior scientist in quantitative pharmacology and pharmacometrics at Merck & Co. Inc., and joined the FDA in 2016 as a clinical pharmacology reviewer, supporting review of dermatology and dental products. Well, welcome, Dr. Liu.
Thank you, Dr. Manabushi. I'm going to talk about clinical pharmacology considerations when conducting studies in menopausal women today. As a disclaimer, this presentation represents my personal opinions and may not necessarily represent the views of the FDA. For today's presentation, I'll begin with some background information, and then give a couple examples where PK differed in postmenopausal women. I will then discuss factors that may contribute to differential PK of drugs among women in different menopausal stages. I'll finally discuss knowledge gaps and opportunities when conducting studies in menopausal women during drug development. As discussed earlier, menopause often happens between 45 and 55 years of age. Perimenopause is the years leading up to menopause, during which women often experience hot flashes. This stage can last for 7 to 14 years. In the United States, there are more than 73 million women who are at least 45 years of age. Most women nowadays spend from a third to half of their lives postmenopausal. Many diseases affect menopausal women, and some of them primarily or only affect menopausal women. Physiological changes associated with menopause or commonly used medications by this population may affect the PK, PD, safety, and efficacy of drugs. Therefore, the effect of menopause deserves attention when developing drugs for patients that include menopausal women. Next, I'm going to present two examples where PK was different between pre- and postmenopausal women. The first example is rosuvastatin, which was mentioned in Dr. Bennett's presentation. Rosuvastatin is a drug approved for multiple indications, including to reduce risk of stroke. Following a single oral dose of 40 milligrams, 5-fold lower exposure was observed in postmenopausal women compared to premenopausal women. The PK parameters are shown in the table, and the figures on the left are the mean PK profiles. As Dr. Bennett also commented earlier, additional research is needed to confirm such a big difference. This is another example. A gel product containing an anti-HIV drug called tenofovir was used in a clinical study for research. The study measured plasma tenofovir concentrations following vaginal administration of the investigational product. The figure here shows that despite high variability, plasma tenofovir concentrations were 10-fold higher compared to premenopausal women. Interestingly, in the group where postmenopausal women were treated with estradiol, plasma tenofovir concentrations were comparable to premenopausal women. The above two examples suggested that menopause status sometimes may impact the PK of drugs. Next, I'll discuss intrinsic and extrinsic factors that could contribute to differential PK among women in different menopausal stages. This figure shows the changes of estradiol and follicle-stimulating hormone, or FSH, during menopausal transition. The black line is the final menstrual period. Estradiol level is lower, while FSH level is higher after menopause. The hormonal changes may modulate expression of proteins or enzymes that are involved in processes of drug absorption, distribution, metabolism, and elimination. However, the patterns of change during the menopausal transition are not uniform across women. This may add some complexity if the impact of menopause on PK/PD is driven by hormonal changes. Transporters are expressed in multiple organs and play an important role in the process of drug absorption, excretion, and uptake for drug metabolism. Efflux transporters like BCRP and PGP transport drugs into intestinal lumen, bile, or urine. Estradiol has been reported to reduce the expression of efflux transporters. Therefore, estradiol level change caused by menopause may affect the drug bioavailability or elimination. In the rosuvastatin example that I showed earlier, the authors hypothesized that higher drug exposure in postmenopausal women could be partly due to reduced level of estradiol concentration after menopause. Rosuvastatin is a substrate for BCRP. In premenopausal women, estradiol concentrations may inhibit the hepatobiliary expression of BCRP, while in postmenopausal women, reduced estradiol concentrations may lead to less or no inhibition on the hepatobiliary expression of BCRP, leading to more biliary excretion of the drug and a lower drug exposure compared to premenopausal women. More research is needed to confirm this hypothesis. As demonstrated in the tenofovir example, menopause may affect the absorption of drugs administered vaginally. On one hand, thinning, drying, and inflammation of the vaginal wall may occur, leading to higher drug absorption. As shown in the cartoon, the number of layers of superficial cells become much less after menopause. On the other hand, higher density of efflux transporters was observed in the vaginal epithelium of postmenopausal women compared to premenopausal women. Increased expression of efflux transporters in the vaginal area could reduce systemic exposure of drugs. In the tenofovir example, the authors also found that epithelial thickness increased after treatment with estradiol in the postmenopausal group. That may explain why plasma tenofovir concentrations after estradiol treatment were comparable to premenopausal women. They also found that expression of some drug transporters reduced after estradiol therapy. Therefore, available data suggests that menopause may impact the PK of drugs delivered vaginally. Also, the use of hormonal therapy may affect the drug absorption of vaginally administered drugs. During perimenopause, many women experience increased fat mass and decreased lean body mass. The left figure illustrates the body fat redistribution as Dr. Miller explained earlier. The right figure shows the fat mass normalized by baseline increased over the years prior to and after final menstrual period. The body composition change may also lead to changes in drug distribution and clearance. Protein binding may change for certain drugs. Many drugs bind to albumin and globulins. In one study, albumin and globulins were measured at different age groups. While globulins didn't change, serum albumin slightly decreased in postmenopausal women. Some drugs bind to sex hormone binding globulin or SHBG. Generally, SHB increases by age, but during menopausal transition, SHBG decreases. This may lead to increased proportion of free drug to exert pharmacological effects or increased clearance, which may reduce or shorten drug effects. Drugs may have interactions. Reduce the drug concentration caused by interactions can compromise the efficacy of a drug. Increase the drug concentrations may enhance the drug's pharmacological effects, but it may also lead to increased adverse reactions. Women in different menopausal stages may be on different therapies. For example, women at pre or perimenopause may be on hormonal contraceptives, while for women at peri or postmenopause, they may be on therapies to manage menopause-related symptoms. And for many postmenopausal women, they could be taking medications to treat diseases like osteoporosis. Therefore, when designing studies during development or evaluating the impact of menopause, different spectrum of drug interaction potential for women in different menopausal stages should be considered. Here are some examples of drug interaction potential for medications used to treat menopause-related symptoms. They can be victim drugs affecting by drugs that modulate the enzymes that play a major role in their elimination. They can also be a perpetrator affecting the concentrations of others. Some of the interactions are clinically significant, leading to contraindications. Therefore, when conducting studies in menopausal women, interactions should be considered to determine whether concomitant use with drugs for menopause related symptoms should be allowed. At this point, there are many challenges when determining if menopause has an impact on drug PK/PD or the efficacy and safety of drugs to achieve the goal of personalized medicine for menopausal women. As Dr. Gassman mentioned, the status of menopause or perimenopause is often not collected in clinical studies during drug development. Although we have many drugs on the market, in most of the programs, it's unknown if menopause would impact their absorption, distribution, excretion, or metabolism, which may lead to different PK. Because menopause status may not be routinely collected during clinical trials, it is unknown if exposure or dose-response relationship for drug safety and efficacy in postmenopausal women differs from that in men or women at pre or perimenopause. Also, as discussed in Dr. Bennett's presentation, sometimes a difference in PK/PD may be observed, but the underlying mechanism is still unknown. With limited information as described above, it is very challenging to determine if findings from men or premenopausal women can be extrapolated to women at different menopausal stages. Also, it is even more challenging to determine if menopausal status should be used for dose adjustment. What are opportunities then during drug development to have a better understanding about the impact of menopause? When developing drugs for patient population that includes women with various menopausal stages, including postmenopausal women early in the program, can help identify PK difference compared to other subpopulations. Collect the menopause status appropriately and collect information about the use of hormonal medications for treatment of menopause-related symptoms. Then the information collected above can be used for subgroup analysis to evaluate the impact of menopause on the dose response or exposure response relationship for safety and efficacy. A good understanding of the impact of menopause using this approach will help determine if the same dose would work for all women in different menopausal stages. Also, models that incorporate menopause status may be developed to inform study design during drug development. In addition, when developing a drug intended to be used in menopausal women, assess its potential of interacting with drugs that they commonly use and develop risk mitigation strategies. With that, I would like to thank my division management, Dr. So, Dr. Tran, Dr. Vidya Nathan, and Dr. Metabushi for their helpful input when I was preparing for this presentation. Thank you all for your attention. With that, I'm going to turn it over to Dr. Metabushi.
Thank you, Dr. Liu, for that excellent presentation on various clinical pharmacology considerations when conducting studies with menopausal women. And thank you to all the other speakers in this particular session for their excellent talks. We will now move on into the question and answer session, and I would like to request our presenters to turn on their camera and their microphones. So we have received a lot of questions coming through, and we'll tee up some of those questions. The first question goes to Dr. Bennett. I see Dr. Bennett's video has not turned on.
The host has stopped me from doing it, so you've got to.
Sure, we'll look into that, but we're glad we are able to hear you and we can see. Okay. Excellent. So the question is, what inclusion criteria should be used to identify women eligible for these clinical studies in menopausal women?
Well, it sort of gets to the question of someone asked, what's postmenopausal versus menopause? And that's a good question, because I think we know what postmenopausal, it's after the menopause situation has happened. So I think the issue, because it's postmenopause, is what we should be looking at. It's too difficult to look during menopause. But Raj, I'd just like to make comments. I want to talk about Dr. Miller's statement that CYP3A is greater than women than men. That's what's in the literature, but that's not true. I showed you the Lemons data where we see a decrease. So maybe in young women, CYP3A is greater. The literature says it, but it's not true. And it goes down, and most women do not have higher CYP3A. In Dr. Liu's presentation of the data on rosuvastatin, if you go look, that's why I showed 2 references from that group. The differences in preclinical women in those 2 studies is 10-fold difference in clearance between preclinical women in those 2 studies. That's why I can't believe any of that data. So part of our problem is that we have a lot of data in the literature that says this is what the situations are now, but we need to go back in the in looking at menopausal women. I wouldn't trust anything that's being said now. And we need to go back, and I think the FDA needs to go back and look to see what are really the data that are important.
Well, can I comment on that?
Sure.
I mean, I think that just emphasizes what we've been saying here when they define men and women. If they don't take into account their age and their hormonal status, who knows what many of these women were? Were they premenopausal? Were they on oral contraceptives? All those data in terms of inclusion criteria in studies are just not really clear from the paper that we use to draw these conclusions. And if that isn't clear in the papers that we're reading, and the data are and it's not collected, and who knows, when those studies were done, those data may not be collected, and it still may not be now.
Sure. Those are all very important, relevant points, and I think those were brought up time and again over the presentations. Yep. Excellent. So now moving on, the next question we have here is for Dr. Gassman. What are the biggest barriers for considering gathering information regarding menopausal status in clinical trials? This is essentially related to the first one. One is asking, how do we identify? And this one is about the various considerations.
Well, I'm going to answer that with in a couple different buckets. I think until very recently, we didn't have good biomarkers to tell anything other than she's in postmenopause. And I think until very recently, there haven't been good efforts to collect information on when people were going through menopause and where they were. And I'm hoping that publications like the STRAW criteria will help us to better identify where people are in the spectrum so that they can be better assessed. The other things, I think, in terms of clinical trial design, I think that there needs to be more thought put into recruiting and enrollment and informed consent of women in clinical trials in general and menopausal women, and what we can do to better ensure enrollment of them, whether it's doing more patient-centric consents or ensuring that clinical trial centers are available. And I also think, just on a personal note, I think that there needs to be involvement of more women in trial design and as co-PIs and involved in research, because I think that the more input we have at the different levels, I think the more inclusive and diverse we will have in terms of clinical trial development.
Excellent. Thank you very much, Dr. Gassman. The next question that we have received here goes to Dr. Liu. What additional data are needed to demonstrate the hormonal changes or physiological changes caused by menopause may lead to changes in the pharmacokinetics and pharmacodynamics of drugs?
Thank you. That's a great question. There haven't been, as we all agree, there haven't been many clinical studies that investigated the effect of menopause on PK/PD of drugs. Also, there are many conflicting data, as pointed by Dr. Bennett, regarding menopause effect on PK, and almost no data regarding menopause effect on PD. Also, some studies even just use the age to make assumptions for the menopause status. So we really need a more high quality data to evaluate this. Also, when conducting studies, menopause status should be appropriately determined, and also other covariates such as body weight, renal function, and hepatic function should be matched so that we do not have those confounding factors. In addition, more in vitro and in vivo data are needed to illustrate potential mechanisms. For example, how do hormones modulate the expression of all different kinds of metabolizing enzymes and transporters? Do menopause impact the PK of drugs that are sensitive substrates of transporters or certain metabolizing enzymes? How do body composition changes during menopause change different processes involved in the PK of drugs? Are those modulations or changes clinically relevant? Answering these questions could help understand if these changes may lead to changes in PK and PD of drugs.
Thank you, Dr. Liu. Thank you very much for that detailed list of considerations. Our next question goes to Dr. Miller. Why is transparency in reporting data from clinical trials key to improving health and reducing adverse events in women as they age? Can you provide some insights?
Sure. When you have data from clinical studies that are the average, that average doesn't show the extremes. It hides many of the data. So disaggregating the data by sex or by age identifies where the results, a reporting of the results, even if it's something as simple as the baseline clinical data that you collect when individuals go into the trial, whether there are differences in those groups to begin with. When you have those data, it really provides you key to where the outcomes may be effective. And there have been many trials, and when we look at this in basic science studies, it becomes even more obvious. When you have a treatment that shows there's no effect of the treatment, but when you dichotomize it by sex, you see it was effective in females or males and not effective in the other group, where the average doesn't show a change at all. Presenting all the data, whether it's done by sex analysis or not, still provides insight into the physiological changes that are associated with that particular intervention. One of the ways in comments to identifying menopause, in the clinical trials, when we collect data on menopause, we ask the age at which, when was the last menstrual period? After that, if it hasn't happened for 12 months, or 6 months, that woman is in menopause. So identifying the last menstrual period and knowing the menopausal age is very different than the chronological age, because there's things that change with time after menopause. And that's been shown in some of the clinical trials, that you intervene with hormones closer to the actual time of menopause, that treatment is more effective than if you wait 5 years later. So knowing menopausal age relative to when you're taking intake data for these drug studies, relative to chronological age is going to be very important as well.
Excellent. Thank you very much. Our next question goes to Dr. Bennett. Can you provide any guidance for study design considerations to study the impact of menopause on investigational drugs, such as those targeting CYP3A or transporters or any other factors that may affect the PK? You are still on mute.
Thank you, Raj. You know, the pediatricians have been arguing for years that children are not small adults. And we should be saying that postmenopausal women are not just old women, are just not old people. I think menopause is different, and we need to be able to separate out what's a menopause kind of relationship and what's a age relationship. And all of the speakers have addressed that. I would like to see, in terms of what the FDA requests from sponsors, is, especially if it's a narrow therapeutic index drug, that at least they begin to address an age versus menopause issue. And if it's a 3A substrate, especially. Now, as we know that many drugs are 3A substrates, but they're very safe over the entire dose range. So I don't think we need to see that kind of information if we have wide therapeutic index for the drug. But when we have a narrow therapeutic index, in the menopause situation, I think it would be valuable to see a change in terms of what we ask sponsors to present to us in information, is at least to begin to address the menopause versus age issue for these narrow therapeutic index drugs.
Thank you, Dr. Bennett. Our next question goes to Dr. Gassman. So nowadays, many clinical trials are conducted globally. How can we extrapolate the data as it's related to menopause if collected for a US population?
That's a very interesting and complicated question. And I think Dr. Richard Davis pointed out that as we understand more and more about this, it is very clear that there are population as well as menopause differences even across regions in the US, as well as across race and ethnicity and menopausal status. And I think global trials need to make sure that when they are seeking approval in the United States, that they have sufficient data to make sure that they are representative of the intended population in the US. And that probably means that there has to be more work on diversifying the menopausal female contingent, if that's the target population, and in ensuring that there is adequate representation in the United States across the states in different areas to make sure that we are capturing the intended population in the US. And I think that's going to take a lot of innovative trial design and more considerations.
Excellent. Thank you very much. Our next question goes to Dr. Liu. Currently, the impact of menopause on PK/PD is not routinely evaluated when developing drugs for disease that affect women of various age or in different menopausal stages. Should the impact of menopause on PK, safety, and efficacy be evaluated in drug development programs to determine if dose adjustment is needed based on menopausal status?
Thank you for the question. I think it is very important to evaluate the menopause status impact, especially for diseases that affect women with different menopausal stages. As I mentioned in my talk, if at early stages you enroll postmenopausal women to characterize the PK and also see if the PK would differ between premenopausal and postmenopausal women, that can help to design phase 2 program to see which doses would be good for dose ranging study. And also in the dose ranging study or phase 3 clinical trials, menopause status can be collected and also Some other covariance information can be collected as well. And then use that information to conduct some subgroup analysis to see whether the menopause would have impact on the dose response or exposure response relationship for safety and efficacy. That will be very helpful for us to have a good understanding of the impact on the PK/PD and efficacy and safety of the drug. That will ultimately help to determine whether a dose would fit for all and whether dose adjustment will be needed for postmenopausal women or women at a perimenopause.
Excellent. Thank you, Dr. Liu. Our next question is for Dr. Miller. How can longitudinal data such as real-world data help provide information regarding changes related to menopause?
Well, I think that we have shown with using longitudinal data, especially from Rochester Epidemiology Project, that it's possible to track incidences of diseases with aging in men and women, and to be able to mine the medical records to see what kinds of conditions or covariants these various individuals may have. So there are a lot of data that are collected from epidemiological studies that can be used to look across the lifespan, but also to evaluate the incidence of not only the incidence of disease, but comorbidities, and to, if the data are in the medical record, to look at hormonal status and pregnancy history and outcomes in terms of morbidity and mortality. Prospective studies can be designed from those longitudinal studies to then recruit different populations to look at an intervention and follow those individuals over several years. We have done that with the hormonal treatment trials and be able to provide excellent data. For example, with the KEEPS trial that we recruited the early menopausal women, they were treated for 4 years with hormones. We're now following them 11 years after they stopped taking the drug to be able to look at their cognitive function, their brain anatomy and pathology, in real time. They're expensive studies. They take a long time, but I think that once they're used, the data are very valuable. Did I hit all the points that you were trying to get there? I kind of wandered off into taking the longitudinal data and doing prospective trials, but I think that that's where it is useful. And now, since many of these medical records are linked across the country, that there is there's many things that can be used. Of course, coordinating them, making sure that the criteria are the same, it's being collected, is going to be key to be able to get data that's useful and clean along the way.
Thank you, Dr. Miller. You did touch upon the longitudinal data and also the challenges associated with accruing such information. Excellent.
Thank you.
Our next question, I'll direct this to Dr. Bennett first. Does currently available physiologically based models already consider changes in enzyme levels in postmenopausal or elderly population?
As far as I can tell, they do not at the present time. I mean, I looked at that question and thought about it. And one of the issues is, as I said before, you don't really find a lot of CYP3A substrates being narrow therapeutic index drugs. Because to get a drug approved, you have to show efficacy and lack of toxicity. Since CYP3A is so variable in just anybody, not just premenopausal versus postmenopausal women, basically those drugs get approved because they can show efficacy and lack of toxicity. So where we're going to be really interested in PK, PD in postmenopausal women is narrow therapeutic index drugs, and they're probably not going to be CYP3A substrates. And as far as I can see, the present PBPK models do not consider this issue in the answer directly, Raj.
Thank you, Dr. Bennett. If I can direct the same question to Dr. Liu, in your experience, have you seen any of these models utilized for understanding the effects of PK in postmenopausal women, or what would be the potential of any of such approaches?
Thank you for the question. I think that's a great question, and that's an area that more effort is needed. I have seen some PBPK models that characterize the PK of estrogens at different doses, at different like a dosing route of administration. But so far, I haven't seen models that incorporated all the physiological changes due to menopause. In the future, if more efforts can be put in this area, such models may be useful to determine some study design regarding what dose to be selected, and whether do we expect a change of PK between premenopausal women and postmenopausal women, and even for women at a perimenopause. I think in the future, probably more effort will be resulting in some good models that we can look at.
Thank you, Dr. Liu. And we have received a lot of great questions from the audience. Unfortunately, we are running out of time. I would like to thank all our speakers and the audience members for their participation, and will now turn things back over to Dr. Bursoff-Macha. Thank you.
Thank you, Dr. Matabushi, and thank you to all of today's speakers and to our collaborators in this meeting, the FDA Office of Women's Health and the Office of Clinical Pharmacology. We'd also like to say a special thank you to Gretchen Carter and the wonderful AV team for supporting this meeting today. And finally, we'd like to thank the attendees for joining us for this very important discussion. As the panelists and moderators have noted, there are many unanswered questions, and today's meeting is an important step to help us better understand both the existing scientific research and the important knowledge gaps around menopause. We hope you've enjoyed the conversation, and a recording of this meeting will be made available in the coming days on the Office of Women's Health meeting website, and the link will be emailed to all registered attendees. And I'd also like to invite everyone to join us for our next public webinar, which is scheduled on November 8th, 2023, Bringing Clinical Research to Patients. And this is from the FDA Office of Women's Health and CDER's Office of Medical Policy. Registration information will be sent to all registrants from today's workshop. Thank you so much and have a good day.